A very good morning to all distinguished speakers and learned delegates. I, Dr. Ayushi Tole, Senior Resident, Department of Orthodontics, Chhattisgarh Dental College and Research Institute, Rajnandgaon, feel privileged to welcome you all on behalf of the organizing committee to the final and second day of the two-day comprehensive webinar on cleft lip and palate. Due to the bad weather conditions yesterday, we experienced some technical glitches. Though not in our hand, we will still try to have a smooth run today. Before getting started, to keep the quality of the sound functional during the webinar, I request all to kindly mute themselves when not sharing the screen. Also, any questions during the session can be typed in the chat box, which will be addressed after the lecture or during the interactive session as time permits. Now, let's start with the proceedings with the auspiciousness and blessings of Goddess Saraswati.
या वीणावरदण्ड या कुन्देन्दुतुषारहार धवला या शुभ्रवस्त्रामृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतं शङ्करं प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा
With the blessings of Goddess Saraswati, may I now request Dr. Jasmine Nindra to deliver her lecture on psychological considerations in cleft lip and palate. Dr. Jasmine Nindra completed her BDS from Pandit B.D. Sharma University of Health Sciences, Rohtak in 2014, following which she pursued Masters in the branch of Orthodontics and Dentofacial Orthopedics from SGT University, Gurgaon. She has been into clinical practice as well as academics ever since the completion of her Masters in 2018. She is now working as an assistant professor, Department of Orthodontics at SGT University. She is also a member of the Indian Orthodontic Society and International Cleft Lip and Palate Foundation. Her clinical interests include fixed mechanotherapy cases and aligner therapy. She received her Smile Train accreditation in 2021 and is dedicated to work for patients with cleft lip and palate. She also has a few research papers published in the indexed national and international journals to her credit. Over to you, ma'am.
As you are aware, the children with cleft, they are at a heightened risk of developing psychosocial problems during their life course, since they are totally different from their peers due to the facial appearance and the potential hearing and speech difficulties. So the main reasons that could be behind these psychosocial issues are their appearance related concerns, the teasing and bullying that they have to go through by their peers, the social stigma, and the facial growth changes that occur over time. So, there are certain psychological aspects that need to be taken into account while treating a cleft child, such as the body image and the facial appearance, their self esteem, the social and the peer interaction, their cognitive development, the emotional or the behavioral problems, and the quality of life. I'll be discussing them individually. Starting with the body image and the facial appearance. So the facial appearance is the main predictor of psychosocial adjustment. Now, individuals with cleft, they see themselves as socially uncomfortable, less appealing, and less satisfied with their facial appearance. This leads to feelings of loneliness and social isolation that is very commonly seen in these children. Second is the self-esteem and self-confidence. Now this refers to how an individual perceives himself. Now in cleft lip and palate patients, less attractive facial appearance may distort the child's self-esteem. Hence, they usually lack the self-confidence, the fear of failure, and they're unable to express themselves. And it is observed that there is low self-esteem more commonly seen in females as compared to the males. Now, when the child receives proper support from the parents, family, and the friends, then the child becomes more accepting of the cleft condition, and this may positively affect the child's self esteem, and a higher self esteem is thus established. Then is the social and the peer interaction. Now, children with cleft condition, they're often rated as less popular by their teacher and the peers or the unfamiliar adults. This leads to a risk of developing difficulty in their social interactions. So, the cleft condition, this may restrict the child's capacity and the willingness to blend in with their peers that affects their psychosocial health. Now, these children, they usually face difficulty in maintaining their friendships and they may often drop out of the school, they detach themselves from the society and predisposes themselves to anxiety and depression. Then let's see how the cognitive development is affected. Now, the children with cleft condition, they may perform more poorly at school and usually have a lower academic record. Now, their learning difficulties that is exacerbated due to the appearance related behavior inhibition, their communication difficulties, the frequent medical appointments that they have, and the long recovery times that is usually there from the surgeries. So these children, they show mild deficit in verbal language along with reading problems. So most commonly, these children, they usually have the intellectual disorder, dyscalculia, or specific learning disorders. Hence, their cognitive development is negatively affected, that results in lower records or the lower academic record in the school. Then is how the emotional and the behavioral problems occur in these patients. Now, most children, they experience difficulties in handling dissatisfaction with their facial appearance and the traumas of these multiple surgeries. So they develop various psychological disorders over some time. Now, the communication problems in these patients is more due to psychological problems than the phonological problems, and this entirely affects the development of the child in a negative manner. Then the psychological problems in these children, it usually manifests in the inappropriate or the unwanted social behavior, then experiences of stigma, their internalization of problems and gaze avoidance, and ultimately leading to anxiety and depression. So the adults with cleft lip and palate conditions, they endured clinical levels of anxiety and depression, which was twice as likely as the healthy controls, and thus they committed suicide in later life. Now, how is the quality of life affected? Now, on a long-term basis, it is observed that the cleft lip and palate patients, they have a poor quality of life. Why? Because of the poor health and dissatisfaction with the facial appearance that leads to the poor quality of life. Now, recently, considerable awareness and attention regarding the psychosocial effects of left lip and palate has led to enhanced surgical technique and proper sequencing of the procedures that has led to improvement in the outcome of the repair of the cleft lip and palate. Now, after surgical treatment, the patients generally perceived improvement in the quality of life, but they may still worry about the self-concept, their psychological well-being, and they would like to get further treatment in order to minimize the scars as soon as possible. It is also observed that there is a psychological impact of these cleft lip and palate patients on the family as well. Now, since the parents, they are usually shocked and they experience helplessness and despair, leading to severe emotional crisis for the parents. Now, the parental stress is due to the feeding problems, the limited speech skills, and strained interpersonal relationships. So, the parents, they are initially embarrassed and they feel guilty about the birth of a cleft baby in their family. So, the psychosocial counseling and interventions is required for not only the cleft patients but also for their parents as a support system to help them cope up with the condition and face the challenges associated with it more efficiently. Now, these psychosocial interventions, they may intensify their quality of life, their self-concept, the social support, and this diminishes their anxiety and depression. Now, I'll be discussing all of these individually. Starting starting with the parental education, the parents must get immediate information about the malformation, its etiology, and the associated complications like the feeding difficulties, ear infections, speech delay, and the dental problems. And a precise information concerning the cleft lip palate, the treatment procedure, and the prognosis, this must be provided to conquer the parents' anxiety and distress. Now, the parents group, it can be formed in order to provide the education and refer the parents to online resources, websites, or the books on cleft lip palate conditions. Also, a psychologist can be appointed in order to deal with the parents' shock and confusion. Next is enhancing the parental social support and coping skills. Now, the social support from friends, family, the cleft support groups, it is regarded as a valuable tool during the process of coping, since it contributes to an exceptional feeling of belongingness, a greater sense of value, a higher self esteem, and a positive outlook. Now, this usually includes seeking support from others like problem solving, then logical analysis, and positive appraisal of the child. Next is the social skills training for these individuals, and it has been shown to be an effective intervention to enhance the coping and to improve the interpersonal skills in order to reduce their social anxiety. The researchers have developed a social skills training program in a group format, and the main features of this program are shown in this figure. So first is in order to improve their social perception and the information processing by the cleft child. So for this, we can improve their face reading skills. That is usually done using emotion identification games, then use of facial expression cards, or discuss the consequence of specific emotions. Second is how to respond and send the social skills. Now for this, usually the non-verbal and the verbal communication skills are improved. Now for the non-verbal communication, we can help them in and explain them how to greet the people, maintain and how to maintain a good body language, to show attention and interest in interactions. So all this will lead to improvement in the non-verbal communication by these patients. Now for improving the verbal communication, we can take up certain topics for conversation and debates on certain topics, and then we can train them on how to respond to people in the right tone and how to share their personal experiences. So with this, I conclude my presentation that regardless of the culture, the psychosocial functioning of the individuals with cleft lip and palate is affected negatively throughout their lifetime. So if a child does not receive sufficient and immediate support from the treating team and the society, it can increase the risk of developing the psychosocial problems. Hence, patient-centered psychological care is essential, and it should continue throughout the lifespan in order to meet the needs of the patients over time. Thank you so much for your patient listening. It was a short and crisp lecture on the psychological considerations in patients with cleft lip and palate. Thank you so much.
Thank you, ma'am, for the valuable insights on the topic. The social skill training for CLP patients can be a boon for them and the patients and the parents as well. Thank you, ma'am, for bringing our attention to these. Ma'am, please accept the certificate.
If there are any questions, it can be taken right now. I would like to thank Dr. Jasmine, who is online with us.
Yes, sir. Good morning. You're welcome.
Good morning, ma'am. Yeah, thank you so much for taking out time and delivering 2 lectures for the same event. Thank you, ma'am. Thank you. I could not personally thank you yesterday. And hopefully everyone has understood, so there are no questions right now. If there are any questions, then we can have posted on WhatsApp group also, and we can discuss it later also.
Sure, sir. Anytime. Thank you for giving us the opportunity to present the lecture on this platform, sir. Thanks a lot.
Thank you. Thank you so much.
Going forward, may I now call Dr. Seema Thakur ma'am to deliver her lecture on the role of pediatric dentist in the management of cleft lip and palate. Dr. Seema Thakur, completed her graduation and post-graduation in pediatric and preventive dentistry from King George Medical College, Lucknow. She endorses an 18 years of teaching and clinical experience as a faculty in the Department of Pediatric and Preventive Dentistry, Himachal Pradesh Government Dental College and Hospital, Shimla, and presently is the professor and head of department of the same. She introduced a newer concept of pre-surgical nasoalveolar molding on infants of cleft lip and palate and has benefited many patients with this technique. Her project on the outcome pre-surgical nasoalveolar molding on patients with unilateral cleft lip palate was recognized and funded by the government. Being associated with many schools for children with special healthcare needs in Shimla, she has been credited with more than 50 publications in various national and international journals and has spread her immense knowledge to the masses by delivering guest lectures at various national conferences. She has also chaired many scientific sessions at various conferences. She has been appointed by Dental Council of India to conduct postgraduate inspections in various colleges and as a university inspector for UG and PG course of the specialty. She has also contributed chapters in an upcoming book in dentistry. She holds life membership of the Indian Society of Pedodontics and Preventive Dentistry, Indian Society of Cleft Lip and Palate, and Craniofacial Anomalies, the Indian Society of Dental Traumatology, Federation of Special Care Dentistry. She is also the Cleft Lip Palate Board member of FSCD. Appointed as a reviewer of ad hoc extramural proposal program of Indian Council of Medical Research, Ministry of Health and Family Welfare, New Delhi in 2017. Her numerous achievements cannot be counted, and her dedication to the field of orthodontics is commendable and should definitely be followed. Over to you, ma'am.
Good morning, everyone. Thank you so much for the nice introduction. I hope my presentation will help all the students in the management of cleft lip and palate. And my aim is that we dentists, because we have very important role in the management, and we have a crucial role rather in the management of cleft lip and palate. And I feel that all the dental surgeons should come forward and help these children. Thank you so much.
Thank you so much, ma'am.
Good morning, and thank you so much for the invitation. Good morning. Good morning, and thank you so much for the invitation. Today, I shall be speaking regarding the role of pediatric dentist in the management of cleft lip and palate. I always love to start my presentations with this picture of my alma mater, King George's Medical University. I have completed my BDS and MDS from this institute itself. Thereafter, I was lucky enough to start my career in a beautiful hill station, Shimla. And here only I'm working as a professor and head in GTC Shimla, which is a branch of Indira Gandhi Medical College, Shimla. This is a picture of IGMC Shimla campus. Coming to the topic itself, now the beautiful part of our specialty. Good morning, and thank you so much for the invitation. Today, I shall be speaking regarding the role of pediatric dentist in the management of cleft lip and palate. I always love to start my presentations with this picture of my alma mater, King George's Medical University. I have completed my BDS and MDS from this institute itself. Thereafter, I was lucky enough to start my career in a beautiful hill station, Shimla. And here only I'm working as a professor and head in GTC Shimla, which is a branch of Indira Gandhi Medical College, Shimla. This is a picture of IGMC Shimla campus. Coming to the topic itself, now the beautiful part of our specialty, that is pediatric and preventive dentistry, is not only that we treat a variety of patients starting from infancy to young adulthood. It is that we get an opportunity to treat the children with special healthcare need. And all of us are aware of the fact that the cleft lip and palate are the most common congenital malformations of head and neck region. If we talk about cleft, cleft is basically a split in the hard and soft tissue element of the body. And the cleft lip is the congenital deformity of the upper lip that varies from notching to a complete division of the lip, and depending upon the severity of the cleft. Similarly, cleft palate is a congenital split of the palate that may extend through the uvula, soft palate, and into the hard palate. The lip may or may not be involved in the cleft of the palate. Coming to the incidence of cleft lip and palate, the worldwide incidence affects cleft lip. If you look at the worldwide incidence, the cleft lip palate affects approximately 1 in 1,000 Caucasians, 1 in 500 Asians, and 1 in 2,000 African Americans. It has been observed that Negroid race has least incidence while Mongoloids have the maximum. The overall incidence worldwide varies from 0.3 to 6.5 per 1,000 live births. Coming to the India, which is the second most populated country in the world with a population of 1.21 billion, it is estimated that out of 24.5 million births per year, the birth prevalence of clefts is between 27,000 and 33,000 clefts. The incidence of cleft lip palate in India only is 1 in 781 live births. Now, this cleft lip is more common in males, and cleft lip palate is more common in females. And unilateral cleft lip palate is more common as compared to the bilateral cleft lip palate. In case of unilateral cleft lip palate, it has been observed that there is a more predisposition towards the left side as compared to the right side. There are more chances of development of cleft in a newborn if both the parents or one of the parent is affected with cleft lip palate, and in cases of consanguineous marriages. Now, this cleft affects not only the parents but also the function, and management of cleft lip palate requires multidisciplinary team approach for the optimum results. Now, the key members of cleft lip palate team are pediatricians, pediatric dentists, plastic surgeons, speech therapists, ENT surgeons, oral surgeons, orthodontists, prosthodontists, psychologists, and last but not the least are the parents, which according to me are the most important and integral members of this team. Now coming to the standards of care for the cleft lip palate patients. These standards of care for children with cleft lip and palate have been created by American Cleft Palate Craniofacial Association. According to it, the fundamental of care requires an interdisciplinary team of specialists with experience in cleft lip palate. Team must see sufficient numbers to maintain expertise. Optimal time for team evaluation is in first few days or weeks of life. Team should assist in adjustment to the birth defects. Team should adhere to the principles of informed consent, form partnership with the parents, and allow their participation in decision making. Care is coordinated by the team and is provided locally if possible and appropriate. Team should be sensitive to cultural, psychosocial, and other contextual factors. Team is responsible for monitoring short and long-term outcomes, including quality management and revision of clinical practices when appropriate. The treatment outcomes must include psychosocial well-being and effects on growth, function, and appearance. Long-term care includes evaluation and treatment in the areas of audiology, dentistry, orthodontics, genetics, dysmorphology, nursing, oral and maxillofacial surgery, otolaryngology, pediatrics, plastic surgery, psychosocial services, and speech-language pathology. Now, coming to the overview of key interventions by age. Actually, the management of cleft lip palate starts from the prenatal period. The parents in which there are more chances of development of more chances of the baby being born with the cleft lip palate, these parents are counseled before the birth of the child regarding what should be expected after the birth. The management actually starts immediately after the birth and lasts approximately till young adulthood. If we see at every age of the birth, the pediatric dentist or other dental surgeon plays very important role in the rehabilitation of such babies. Now coming to the management of cleft lip palate in detail and move with the focus of the role of pediatric dentist in particular in the management. Now the multidisciplinary sequencing of treatment in clefts. The overall management of the cleft lip palate can be divided into 4 stages to simplify the whole procedure. Stage 1 includes the time period from birth to 12 months, 18 months of age. Stage 2 is the primary dentition stage, that is 18 months to approximately 5 to 6 years of age. And stage 3 is the late primary dentition or early mixed dentition stage, that is from 6 to 10 or 11 years of age. And stage 4 is a permanent dentition stage, that is from 12 to 18 years of age. Starting from the stage 1, that is from birth to 18 months of age. The procedures or the issues that has to be resolved during this stage are management of psychosocial issues, feeding management, feeding obturators that are delivered for the management of feeding only, monitoring of ears and hearing, delivery of pre-surgical nasolabial molding appliances or pre-surgical infant orthopedic appliances, The repair of cleft lip and repair of cleft palate is also done during this period only. And further is the assessment of speech and language. Now, starting with the psychosocial issues. Now, the birth of a child always brings happiness in the family. However, if there is a birth of a child with complete cleft lip and palate, who has significantly asymmetric nose, lips, and maxillary arch, the birth of such the birth of such a child and the parents of such a child are filled with traumatic experience at that time only. They are filled with fear, anxiety, and anxiety. There are many psychological issues that parents face at this moment, like anxiety and fear for the child's future appearance, fear of multiple surgeries, recurrence of defect to the unborn children, speech development, intellectual development, financial problems implicated in the rehabilitation of these children. In addition to this, the feeding difficulties that these infants experience can be threatening to new parents who may doubt their own ability to feed and nurture an infant with such differences. The psychosocial issues are a critical part of assessment, and management of the children with cleft lip and palate must be addressed from the onset of care. A pediatric dentist is usually the first dental specialist to meet the parents. The parent needs support and information regarding treatment aspects. It is also very important to negate any fear and guilt regarding the child with the parent that a parent might have. The photos of the treated patients can be used for parent counseling. This is what we actually clinically do in our OPDs and in our hospital as well. Now, coming to the feeding management. The feeding problems are the immediate problems that the parents of complete cleft lip palate infants face. These problems include insufficient suction to pull the milk from the nipple, excessive air intake during feeding, choking, nasal discharge, and excessive time required to take nourishment. The difficulty in feeding make it difficult for the infant to maintain adequate nutrition. Normally, what happens in a normal infant, the soft palate at the back of the mouth moves up to close off the passage to the nose during feeding. This creates a closed system, and the sucking motion creates a negative pressure which pulls the milk out of the breast or bottom. However, in a cleft palate, the infant is unable to is unable to achieve this closed system, and it is impossible for the milk to be pulled out of the breast or from the nipple. The infant will look like he or she is sucking, but actually he or she will be using up precious calories in a futile attempt to gain adequate nutrition. Now, immediately after the birth, the feeding is achieved with the help of nasogastric tubes as an emergency procedure. However, these nasogastric tubes cannot be used for a longer period of time because there is a risk of infection due to these tubes, and there are cases in which these tubes lead to the perforation of the tissues as well. Therefore, we need to look for the other conservative methods for the feeding management. The types of feeding that can be done in these children are breastfeeding, bottle feeding, spoon feeding, syringe feeding, and feeding with the help of feeding obturators. The breastfeeding can usually be, some infants can usually be breastfed with proper nipple positioning and breast compression. Baby is typically placed in a semi-upright straddle or football position, and mother must ensure that the baby has good latch. There are many modification of feeding bottles that are available in the market as well. Like, for example, Medela Haberman Special Needs Feeder. It is a bottle specially designed for babies with poor suction effort. This feeder consists of a large compressible nipple with a one-way valve at its base that keeps the nipple full of milk. Cleft Palate Nurser is another bottle made by Mead Johnson Company. It is a soft-sided bottle that is squeezed in coordination with infant sucking effort, and thus milk is delivered into the mouth. The another bottle that is by Pigeon is also available in the market. This is a squeezable bottle with a long nipple, and this bottle is actually very much economical bottle, and it seems it is a made in India product, and it is easily available in the on the Amazon. We generally recommend our cleft lip palate patients this bottle only. The regular bottles can also be supplemented with special teats, namely newborn teat, orthodontic shaped teat, MAM soft zipper spout, Nux soft cleft palate teat, MAM vented teat size 2 tapered teat. These teeth, however, should not be positioned into the cleft area. The feeding can also be done with the help of a spoon. However, it is very slow and frustrates the babies as well as the caregiver. The spoon may be a conventional type and attached to the special type of feeding bottle which acts as a reservoir. This spoon feeding is actually helpful after the repair of the lip or the palate. Another method is with the help of syringe. A soft rubber tubing can be attached to the syringe to facilitate feeding of infant with limited suction effort. The milk is gently flowed into the buccal space to time with the baby's suck, swallow, breathe pattern. It is sometimes used for lip and palate surgery. Now, the method of feeding is also modified for these babies. The parents should be told to hold and nurse the infant so that increased bonding occurs. The child should be kept in a semi-upright position because this position helps. In this position, because of the gravity, the milk is prevented from coming out of the baby's nose, and it also limits choking and decreases the risk of middle ear infection. Now, these infants, whichever the method we are opting, these infants tend to take in a lot of air while feeding. Therefore, these infants need to be burped at a regular interval. They need to be burped more than the normal infants, and after the regular interval. That is like what we suggest parents that do the burping approximately after 3 or 4 minutes after in between the feeding also. Now, coming to the feeding obturators. These feeding obturators are the plates which are used to assist feeding in these infants. These plates can be used with the modified bottles as well as regular bottles also. These feeding plates are made with the help of acrylic, or they can be made with the help of thermoform plastics, thermoform acrylic silicone material as well. Immediately after the birth, or as early as possible after the birth, impression is taken, and on the model, after blocking the undercuts, the feeding plate can be made with the help of acrylic and with the other material, as I have told, that is thermoform acrylic silicone material. A dental floss is tied on the anterior portion of this feeding plate so that the parents can hold the this feeding plate with their finger while feeding, so that there is a lesser risk of falling back of this feeding plate while feeding the child. Now the plate is removed after every feeding and stored in a moist container. The feeding plates are required to be changed after every 4 to 6 weeks to accommodate the palatal growth. Now, another important treatment part that is done during this period is pre-surgical infant orthopedics. And for this is done by the pediatric dentist or orthodontist, or sometimes in certain cases, prosthodontists also do this procedure. The wider and extensive clefts as seen in the complete cleft lip palate cases are deficient in hard and soft tissue elements and pose a significant surgical challenge to achieve functional and aesthetic outcomes. Ideally, deficient tissues should be expanded and malpositioned structures should be repositioned before surgical correction, all allowing for a less invasive surgery to the patients. Therefore, the desire to reduce the surgical challenges of cleft lip and palate led to the advent of pre-surgical infant orthopedics. Now, this pre-surgical infant orthopedics is an umbrella term that covers any treatment of an infant's cleft deformity before the definitive primary lip surgery. Now, let's have a look at the brief look at the background of pre-surgical infant orthopedics. There have been numerous techniques documented over the centuries to improve the position of the cleft alveolar segments. The early evidences of surgeons' attempts to reduce the severity of the deformities before the primary surgical repair to achieve a better outcome came as far back as the 16th century. In 1686, Hoffman described the use of head cap with the arms extended to the face to retract the premaxilla and narrow the clefts. There have been many improvements to this method of using the head as extraoral anchorage. In 1790, Dissault used a similar technique to retract the maxilla before surgical repair in bilateral clefts. In 1844, Hallihan stressed the importance of pre-surgical preparations of clefts using adhesive tapes binding, as Mark and Kowalczyk used a bonnet and strapping to stabilize the premaxilla after surgical retraction. In 1927, Brophy demonstrated passing of silver wire through the both ends of alveolus and tightening to narrow the cleft. However, the concept of intraoral device to reposition the cleft alveolar segments is attributed to McNeil in 1950. Through a series of acrylic plates, the segments were actively molded into the desired position. Later on, Buston popularized this technique. In 1975, Georgette and Latham introduced a pin-retained appliance to simultaneously retract the premaxilla and expand the posterior segments over a period of days. In response to controversies associated with active retraction of the premaxilla, Holtz described the use of passive orthopedic plate to slowly align the cleft segments. Now, this pre-surgical infant orthopedics aims at securing a good maxillary arc form in an acceptable relation with the mandible and at restoring normal oral function. However, all of these appliances were designed to correct the alveolar cleft only, despite the fact that the cleft nasal deformity remained the greatest aesthetic challenge. In 1993, Grayson et al. Described a technique to correct the alveolus, lip, and nose in infants born with cleft lip and palate. This led to the advent of pre-surgical nasoalveolar molding. Now, this pre-surgical nasoalveolar molding is a non-surgical method of reshaping the gums, lips, and nostrils before cleft lip and palate surgery, thus lessening the severity of the cleft. Now, a typical cleft pre-surgical nasoalveolar molding appliance consists of two segments, intraoral appliance and extraoral taping. The intraoral appliance consists of three segments. The one is the alveolar molding appliance. This is rested on the alveolar segments. The second is retentive button. This is to hold the appliance, and the third one is the nasal stent. This nasal stent helps in the molding of the nasal alar cartilages. This nasal stent, there is one nasal stent for the unilateral cleft lip palate patients, whereas for the bilateral cleft lip palate patients, there are two nasal stents to remodel these two nasal alar cartilages and to elongate the columella as well. This intraoral appliance is secured extraorally to the cheeks bilaterally by the retentive surgical adhesive tapes wrapped around an orthodontic elastics at one end. The elastic then engages the retentive button. The clinical procedures and fabrication of pre-surgical nasoalveolar molding plate should be started in first week or early second week after the birth, as molding of tissue is easier. PNAM should ideally be completed before 6 months of age. Now, coming to the benefits of this pre-surgical nasoalveolar molding, in the long-term studies indicate that the change in nasal shape is stable with less scar tissue and better lip and nasal form. This improvement reduces the number of surgical revisions for excessive scar tissue, oronasofissulas, and nasal and labial deformities. With the alveolar segments in better position and increased bony ridges across the clefts, the adult teeth have a better chance of erupting in a good position with adequate periodontal support. PNAM reduces the number of surgeries and need for alveolar bone grafting, hence saving the child from pain and psychological trauma. The whole process of pre-surgical nasoalveolar molding is very much cost-effective. The results are far more aesthetics. This pre-surgical nasoalveolar molding also serves a dual functioning by acting as a feeding appliance as well. Another important benefit of nasoalveolar molding is the opportunity for the parents to actively take part in the habilitation of their child. The main limitation of this whole procedure is that it requires a high degree of compliance of parents during treatment, and it may not be practical in situations where parents must travel a great distance for weekly care. This treatment procedure need multiple visits. Now, next comes the chyloplasty and palatoplasty. These two procedures, this chyloplasty and palatoplasty, are also undertaken during this stage only, that is stage 1. The chyloplasty is preferably done between 3 to 6 months of age, depending upon the choice of the plastic surgeon. And the rule of 10 plays very important role, is very important criteria for the lip repair. It states that at the time of surgery, the age of the child should not be less than 10 weeks, and the HB should not be less than 10 grams, and the child should not weigh less than 10 pounds. The various types of lip repair are Millard's repair, and tennis and Rendon repair. Afterwards, palatoplasty is done, which is done at the age of 12 to 18 months, as this correlates with the age at which most children begin to talk. This also improves hearing and swallowing. It is important as speech therapy is critical at this age. Next comes the primary dentition stage, that is from the 18 months till 5 or 6 years of age. During this stage, treatment is initially focused on establishing and maintaining oral health to reduce the possibility of the development of dental caries. The ectopic eruption of primary maxillary anterior dentition may lead to dental caries during this stage. Management of cleft lip related speech problems are also undertaken during this stage. The oral health care and prevention of dental caries is very crucial step that should be taken during this stage, because these children are more prone to dental caries, and prevention of dental caries is of utmost importance, especially in these children. Young patients with cleft lip palate are often have associated middle ear infections and consequent hearing difficulties. And above that, they have the upper respiratory tract infection also. These children may have history of frequent course of antibiotics for repeated ear infections. They may be under the care of ENT surgeon and required to be operated under general anesthesia. It is required to obtain full detail concerning the child's prescribed medications. Administration of sucrose-containing medicines can give rise to dental caries. It is essential to explore the possibility of sugar-free alternatives in these cases. Parents may be nervous to brush in the region of cleft, especially following primary lip and palate surgery. They often think that the bleeding from the gingival inflammation is caused by damage from toothbrushing or breakdown of surgical repair. Therefore, parents should be shown in detail how to brush the teeth and gums properly. It is important to point out the potential problem areas of plaque accumulation around the teeth in the cleft region. Where the upper lip has been repaired, parents should be shown how to lift it, stretching the lip carefully by sliding an index finger along the labial gingiva without doing any damage to the scar. This helps to give them a clear view of the cleft region with good access to the crowns of anterior teeth and the gingival margins for plaque removal. For the toddlers, parents are advised to stand or kneel behind the child when brushing, with the chin supported and head resting against the parent's chest. A fluoride children's toothpaste containing no more than 600 ppm fluoride is recommended for children under 6 years of age to reduce the likelihood of enamel opacity in the permanent teeth. Children with high risk of developing caries should use a standard toothpaste. Parents should be given the opportunity to practice the toothbrushing technique in the operatory. A twice yearly professional application of topical fluoride varnish is recommended. Now, coming to the cleft-related speech consideration that has to be undertaken during this stage only, because the child starts speaking during this stage only. The children with an unrepaired cleft palate are not able to separate the nose from the mouth. Even after surgical closure of the palate, some children are unable to create adequate intraoral pressure for normal speech. Any problem with the child's ability to separate the nose from the mouth during speech is called velopharyngeal dysfunction, or VPD. Speech and language assessment should take place regularly. Some types of VPD can be treated with speech therapy alone, and other types of VPD require surgery or prosthesis. Now, this fabrication of speech prosthesis, again, the pediatric dentist or prosthodontist play a very important role. This speech prosthesis is a removable appliance that is attached to the teeth with a wire clasp and is fabricated by a dental specialist in conjunction with the speech-language pathologist. There are two types of speech prosthesis, lifts and obturators. A palatal lift appliance lifts the palate in order to create a velopharyngeal gap. An obturator closes the velopharyngeal gap with an acrylic bulb that matches the gap size and shape. The design of the prosthesis is determined by the instrumental VPD evaluation, and its fit is modified and defined and fine-tuned as needed. Due to the significant improvements in the surgical approaches for the treatment of VPI, many teams no longer use obturation as a treatment modality nowadays. Now, the advantages of these speech prostheses are: in the young child, it allows the development of correct speech sounds, improves intelligibility, and may diminish behavior problems due to communication difficulties. The speech bulb is indefinitely adjustable in size and shape and requires minimal movement of the velopharyngeal structures to work well. It is removed at night, so it does not cause obstructive sleep apnea. Prosthetic treatment provides a reversible trial for controlling VPI before committing the child to a surgical procedure. Prosthetic treatment makes control of VPI available to patients for whom surgery is not advised. Now, the disadvantages are: it requires parent commitment, patient compliance, and professionals skilled at working with the children. Initial desensitization needed to reduce the gag reflex. It requires modification as the child grows, requires many office visits for the development and adjustment. Long-term presence of the removable dent processes make oral hygiene difficult and increases the risk of cavities and periodontal problems. It can be lost and can be broken as well. Next comes the stage 3, that is the late primary stage and early mixed dentition stage, and it starts from approximately 6 to 7 years age and till the 12 years of age. The problems that are faced during this stage are ectopically erupting permanent central and lateral incisors and crossbites of the posterior dental segments. Now, the treatment modalities for correction of developing traumatic occlusion and posterior crossbite segments are maxilla expansion. These maxilla expansion is done to correct the posterior segmental collapse, followed by passive holding appliances. And alveolar book left bone, this maxilla expansion can be done with the help of slow maxilla expansion appliances like fixed one, like quad helix W arc appliances, and Rapid maxillary appliances, rapid maxillary appliances are actually rapid RMEs, rapid maxillary expansion appliances actually are not required for such cases, because actually there is no fusion of the suture in cleft palate cases. Therefore, these slow maxillary expansions solve most of our purpose of expansion, and this expansion should be followed by the alveolar bone grafting. This alveolar bone grafting provides a bony support for the teeth adjacent to the cleft and provides bone through which the teeth can erupt. It offers maxi-arc continuity. It aids in the closure of the oronasal fistula and supports the alar base of the nose. After this mixed dentition phase comes the permanent permanent dentition stage, that is from 12 years to 18 months of age. Some patients require conventional orthodontic management during this age, while some require combined orthodontic surgical approach in the permanent dentition following full diagnostic examination. Most orthodontic surgical procedures involving the maxilla and mandible are deferred until the teenage years, when maximum growth of the jaw has been attained and all the permanent teeth except the third molars have erupted. In boys, the osteotomies should be delayed to approximately 17 to 18 years of age, while in girls, due to early maturation, osteotomies can be done after the age of 15 years. The cosmetic surgeries like major nasal bone surgeries can be deferred until the patient is in early teens and after the orthodontic surgery. These procedures help restore projection symmetry, refinement, and airflow of the nose. The final surgical lip revision can also be deferred until the completion of any surgical or orthodontic treatment that will change the osseous and dental support of the upper lip, and until the mid to late teens to eliminate variable of future facial growth on the surgical result. Finally, to conclude, I would say that the role of pediatric dentist starts from the neonatal period right up to the permanent dentition phase. Pediatric dentists perform a dual role in both improving the personal impact as well as improving the surgical outcome. Throughout the treatment planning, patient support, skillful behavior management are important aspects of this multifaceted care. These are the references and further suggested readings. Thank you for the patient listening.
Thank you, ma'am, for the lecture and for the detailed interdisciplinary treatment planning considerations for CLP patients. I may now request Dr. Achin sir to kindly present the certificate to ma'am.
Thank you so much, ma'am. It was quite a wonderful lecture. I wish we could have listened to you live. If you could have visited us, maybe in future we'll have you here, ma'am. Kindly accept the certificate of appreciation, ma'am. Thank you so much.
Thank you, sir. Thank you, sir. Am I audible? Thank you, sir.
Yes,
Thank
you are
so
audible,
much.
ma'am. Thank you.
Thank you. Thank you so much.
Going forward, it has been shown that for optimum concentration, a 10 minutes break in between learning can be very beneficial. Hence, we shall pause for a 10-minute break and start after 10 minutes precise. We now proceed to therapy, which I invite Madam Kiran Kamble. Madam Kamble has been working as a special educator at National Institute for the Mentally Handicapped. Earlier, she had worked at the District Disabled Rehabilitation Center Wardha and Kasturba Health Society. She had completed her diploma in special education, hearing impaired from the Ali Yavar Jung National Institute for the Hearing Handicapped, Mumbai in 2000, following which she pursued B.Ed at YCMOU Nashik in 2018. She has been continuously developing her knowledge by attending Pan-India CRE programs. She is also blessed with a great voice and has won many singing competitions. She has also conducted many social welfare and guidance programs in rural areas and constantly working towards catering her service to the many special needs people and children. Over to you, ma'am.
Hello everyone, dear doctors and friends and students. I am Kiran Kamble. assistant speech therapist in ENT department and Savangi Megi, AVBRH. आज हम स्पीच थेरेपी के बारे में जानने वाले हैं। स्पीच थेरेपी क्या होती है और किन लोगों को दी जाती है, इस बारे में हम जानने वाले हैं। तो उससे पहले मैं कहना चाहूंगी कि speech is an important part of our personality because looks and beauty can only gain attraction, but the speech and good language can win hearts forever. Also, speech is a better way for self-expression and language is the medium of communication. हम सभी जानते हैं कि हमारी जो पर्सनैलिटी है उस पर्सनैलिटी में स्पीच कितना महत्वपूर्ण हिस्सा है। स्पीच की वजह से हमारी पर्सनैलिटी डेवलप होती है। स्पीच की वजह से हम अपनी भाषा का आदान प्रदान भी करते हैं, हमारे विचारों को, हमारे भावनाओं को अभिव्यक्त करते हैं। तो स्पीच और लैंग्वेज एक ही सिक्के के दो पहलू है, लेकिन स्पीच मतलब वाणी जिसकी सहायता से हम बोलते हैं। वाणी में लाइक टंग है, उसके बाद लिप है, सॉफ्ट पैलेट है, इनकी हलचल से संबंध होता है वाणी का। और जो लैंग्वेज है, लैंग्वेज प्रतीकों के द्वारा अभिव्यक्त हुए अर्थ से लैंग्वेज का संबंध होता है। भाषा जो बोली जाती है वो अलग अलग प्रतीकों के द्वारा बोली जाती है, उसका अर्थ हमको समझ के उसके बाद हम बोलते हैं। लेकिन वाणी जो है, वाणी का संबंध ओनली टंग मूवमेंट्स, उसके बाद सॉफ्ट पैलेट की मूवमेंट, जा की जो बोलना है उससे संबंधित है। तो भाषा प्रतीकों द्वारा अर्थ व्यक्त करने का एक तरीका है और वाणी भाषा को अभिव्यक्त करने का साधन है। तो हम जो बोलते हैं वो जो स्पीच है, हम जो बोलते हैं भाषा, जब बोलना शुरू करते हैं तो हमें ये बहुत सारी चीजें जरूरी है, जैसे टंग है, सॉफ्ट पैलेट है, लिप है, ये इनका करेक्ट होना जरूरी होता है। और भाषा कई तरह की होती है, जैसे कि साइन लैंग्वेज होती है, चित्रों की भाषा होती है, उसके बाद लेखी भाषा होती है और बोली भाषा, हम लोग बोलते हैं बॉडी लैंग्वेज भी एक भाषा है। तो ये सारी भाषा है, लेकिन जो बोली लैंग्वेज है, जो बोली भाषा है, उनमें हम स्वर और व्यंजन आते हैं बोली भाषा में, और वो उनका संबंध होता है हमारे ध्वनि से, कि हम वो कैसे निकालते हैं, कैसे प्रोड्यूस करते हैं। शब्द शब्द बोलने के बाद शब्द निकालना है, मतलब शब्द स्वर और व्यंजन से जुड़ा होता है। और इस प्रकार हर भाषा के प्रतीक होते हैं। भाषा प्रतीकों के अर्थों से जुड़ी है। अपने गले में उपस्थित जो वॉइस बॉक्स है, स्वर यंत्र की वजह से हम सूक्ष्म फर्क होने वाली अलग अलग ध्वनि निकाल सकते हैं, और इस ध्वनि का नियमबद्ध रचना भाषा की पद्धति को सिद्ध करता है। स्पीच एंड लैंग्वेज ये एक ही सिक्के के अलग अलग पहलू है। वाणी का उच्चारण सही हो तो भाषा सही होती है। अब भाषा जब हम बोलते हैं तो हम सभी जानते हैं कि भाषा का एक अलग महत्व है। भाषा ऐसे ही नहीं कि हम लोग बोलते जा रहे हैं बोलते जा रहे हैं। भाषा कहाँ कैसी होती है, भाषा के नियम होते हैं। कहीं हम मतलब कहाँ किस चीज पे, किस जगह पे है, उस जगह को संबंधित हम भाषा का उपयोग करते हैं। जैसे कि हम कोई भाषण दे रहे हैं तो हमको कहाँ रुकना है, कहाँ आवाज बड़ी करनी है, कहाँ ट्रेस देना है वर्ड पे, कहाँ हमको स्लो होना है, कहाँ पूर्ण विराम देना है। भले ही बोलते हुए नियम नहीं, लेकिन व्याकरण हमारी भाषा बोलते हुए दिखाई देना चाहिए। कि हम कहीं मान लो कि हमारा रिजल्ट सही नहीं आया तो हमारी आवाज स्लो हो जाती है कि मुझे मार्क्स कम हो गए। और हम अगर बहुत अच्छे मार्कों से पास है तो हम बहुत चिल्ला के बोलते हैं कि आई एम विन, मैंने बहुत अच्छे मार्क्स पा। तो हमारे मूड और हमारे चीजों को भी भाषा अभिव्यक्त करती है, और हम भाषा के नियमानुसार ही बोलते हैं। अब सही भाषा बोलने के लिए हमको सबसे पहले देखना पड़ेगा कि हमें क्या क्या चीजें चाहिए है। अब सही भाषा बोलना है यदि हमको, तो जैसे लाइक हमको पूरे नियम पता होने चाहिए। हम सारे लोग जो भाषा पहले सुनते हैं और उसके बाद उसका अनुकरण करके सीखते हैं। तो भाषा बोलने के लिए सबसे पहले वाचा होना जरूरी है। वाचा मतलब वाणी। अब वाणी का करेक्ट होना जरूरी है, क्योंकि शब्द मैंने जो बोले कि स्वर और व्यंजन है, वो निकालने के लिए 3 चीजें जरूरी है। तो हम आगे बढ़ते हैं, वो आगे मैं आपको बताऊंगी। पहले हम ये देखते हैं कि हु डज लैंग्वेज थेरेपिस्ट। अ स्पीच लैंग्वेज पैथोलॉजिस्ट, आल्सो कॉल्ड स्पीच थेरेपिस्ट, treat many types of communications and swallowing problems. They have at last master degree and state certificates. Speech language pathologist helps kids with speech disorder like stammering, faulty pronunciation, hearing problems, and other medical conditions, including cleft palate. अब हमें देखना है कि हम स्पीच हमारा कैसा प्रोड्यूस होता है, स्पीच मैकेनिज्म क्या होता है। सबसे पहले स्पीच में रेस्पिरेटरी सिस्टम जो है वो काम करती है, क्योंकि उसका जो लंग्स है, पैलेट है, अभी आपके सामने है कि जैसे नेजल कैविटी है, ओरल कैविटी है, टंग है, पैलेट है, वॉल्यूम है और वॉइस बॉक्स है, लंग्स। तो ये सारी चीजें जो है वो हमारी स्पीच प्रोड्यूस करने के लिए हेल्पिंग का काम करती है। जैसे कि मैंने कहा कि स्पीच हम कैसे बोलते हैं, अभी मैंने आपको बताया कि स्पीच इज अ प्रोड्यूस बाय ब्रिंगिंग एयर फ्रॉम द लंग्स टू द लैरिंग्स। ये रेस्पिरेटरी सिस्टम है। उसके बाद वेयर द वोकल फोल्ड्स में बी हेल्ड ओपन टू अलाउ द एयर पास थ्रू और मे वाइब्रेट टू मेक अ साउंड। ये फोनेशन है, तो ध्वनि के लिए हमको हमें चाहिए होता है। द एयरफ्लो फ्रॉम द लंग्स is the speeded by the articulation in the mouth and nose. तो articulation जब हम बोलते हैं या व्यंजन निकालते हैं, तो हवा का जो स्पोर्ट होता है वो जहाँ पे हवा अड़ाई जाती है टंग द्वारा, और उसके बाद आर्टिकुलेशन का निर्माण होता है। जैसे कि मैंने आपको बताया कि स्पीच में जो बोलने के लिए हमें जो चाहिए वो वाले जो ऑर्गन है, वोकल स्पीच ऑर्गन, वो है माउथ, नोज, थ्रोट, लैरिंग्स एंड लंग्स। अब प्लेस ऑफ आर्टिकुलेशन। जब हम बोलते हैं, जो भी स्पीच हम भाषा बोलते हैं, वो शब्दों से बनी होती है, स्वर्स और वोवेल्स। तो स्वर बोलने के लिए हमें कहीं अटकाव नहीं होता है, जैसे अ, आ, ई, उ, ए, ऐ, ओ, औ, आहा। लेकिन जब हमें व्यंजन बोलना होता है, तो व्यंजन बोलने के लिए हवा का एक स्पोर्ट होता है जहां अटकाव करना होता है और हमें वो व्यंजन का निर्माण करना होता है। कि जैसे हम जो भी, मैंने जैसे बताया कि हम जो भी बोलते हैं, सांस लेना और सांस छोड़ना, इसके इस बीच की प्रक्रिया जो होती है, उसके हम बोलने को अंजाम देता है। बोलना जो है वो वाणी का दूसरा दुय्यम कार्य बोला जाता है वैसे, क्योंकि जैसे हमको जो टीथ दिए है, दांत है, टंग है तो टेस्ट के लिए है, दांत है तो चबाने के लिए है, मुंह जैसे खाने के लिए है। लेकिन सभी प्राणियों में ये सारी चीजें अवेलेबल है, लेकिन मानव प्राणी बहुत बुद्धिमान होने की वजह से उसने भाषा का निर्माण किया, भाषा को ढूंढा, और उसने वाणी का उपयोग इस भाषा बोलने के लिए किया है। तो हम जो भाषा बोलते हैं वो शब्दों से बनी होती है, स्वर और व्यंजन से। तो स्वर हम इजीली बोल सकते हैं अ से अम तक, और जो व्यंजन होते हैं उनके लिए हमें उच्चारण के लिए अलग अलग स्थान निर्धारित होते हैं। जैसे हमें त बोलना है, त के लिए दांत को टंग लगनी चाहिए, त, थ, द, ध। ठीक है। उसके बाद ओष्ठीय जो जैसे रहते हैं, ये बैवल्स अगर बोलेंगे तो प, फ, ब, भ। उसके बाद ट, ठ, ड, ढ। रेलिंग्स फिर पैलेटल व्यंजन होते हैं, क, ख, ग, घ। उसके बाद र। इस तरह हमको अलग अलग टंग्स जो है उनके जो प्लेस ऑफ आर्टिकुलेशंस अलग अलग रहते हैं, कि वहां हम लगाएंगे तभी वो व्यंजन का उच्चारण होगा। उसी प्रकार मैनर ऑफ आर्टिकुलेशंस, जैसे कि हम कुछ बोल रहे हैं, जैसे प, फ, ब, भ ओष्ठीय वर्ड्स हुए, प, फ, ब, भ। अब प के लिए भी लिप एक दूसरे को जुड़ रहे हैं और फ के लिए जुड़ रहे हैं, लेकिन फ बोलते हुए एक ध्वनि का निर्माण होता है कि फ, हवा बाहर निकलती है और उसके बाद फ। लिप भी जुड़ रहा है और हवा भी बाहर निकल रही है, तो प फ। फिर ब भी प की तरह होता है, लीप होते हैं लेकिन हवा नहीं निकलती, लेकिन भ बोलते वक्त भी हवा निकलती है, भ। तो जो ध्वनि है उसका मैनर ऑफ, उसका तरीका भी सही होना चाहिए ध्वनि बोलते हैं। तो कुछ स्पर्श ध्वनि रहते हैं, कुछ स्पर्श संघर्ष ध्वनि है, जैसे साफ पसिव है, उसमें प फ ब भ आते हैं। फिर एफ्रिकेट्स में आता है कि स्पर्श संघर्ष ध्वनि, च छ ज झ। फिर फ्रिकेटिव घर्ष ध्वनि है ये, जिसमें स फ व। फिर नेजल जो है म और न। फिर ट्रेल्स में र आता है, जिसमें कंपन युक्त ध्वनि, जिनको हम व्यंजन बोलते हैं, र। इसमें कंपन आता है, इसको ट्रेल्स बोलते हैं। फिर लेटरस है तो पार्श्विक, उसमें ल आता है। और सेमी वोल्स में अर्धस्वर, जैसे व और य। तो व और य जो अर्धस्वर क्यों बोला जाता है, इसके लिए हम जैसे कि व ऊ से शुरुआत, ऊ से शुरू होके व का निर्माण होता है, इसीलिए उसको अर्धस्वर बोला जाता है। य, ई से शुरू होता है, और य। ठीक है, तो ये मैनर ऑफ प्रोडक्शन का जो चार्ट है कि ये कैसे अपन प्रोड्यूस करते हैं, प फ ब ब कहाँ से, उसके बाद लैंग्यूल डेंटल त थ द ध, उसके बाद पैलेटल वर्ड्स कौन से है, ये चार्ट दिया है। फिर हम देखेंगे कि व्हाट इज क्लेप पैलेट। तो क्लेप पैलेट के बारे में आप सभी लोग जानते हैं कि फिर भी मैं बताना चाहूंगी कि क्योंकि हमको क्लेप पैलेट को ही स्पीच थेरेपी के बारे में बताना है, तो थोड़ा क्लेप पैलेट के बारे में जानना है कि उनको स्पीच प्रॉब्लम किस वजह से होते हैं। तो सभी को पता है कि द क्लेप पैलेट में कि क्लेप लिप result in an opening in upper lip. The opening, the lip can be a small slit, or it can be a large opening that goes through the lip into the nose. A cleft lip can be on one or both sides of the lip, in the middle of the lip. Children with cleft lip can have cleft lip palate. तो उनको पैलेट में छेद होता है अंदर, और लिप लिप में भी प्रॉब्लम होता है, लिप भी कटा हुआ होता है, कभी दोनों साइड कटा होता है, कभी बीच में कटा हुआ होता है। तो मैंने जैसे बताया कि हम जो स्पीच बोलते हैं, तो हमारे टंग मूवमेंट्स, टंग प्लेस हमारा सही होना चाहिए। तो हम देखेंगे कि आगे क्लेप पैलेट को क्या दिक्कत है। द प्रॉब्लम्स रिगार्डिंग स्पीच इन क्लेप लिप पैलेट। तो क्लेप लिप के जो प्रॉब्लम फेस करते हैं वो इस तरह से कि उनको डेवलपमेंटल डिले इन स्पीच एंड लैंग्वेज। उनको जो प्रॉब्लम होता है सांस लेने का, उनका तरीका सही नहीं होता। उसके बाद उनके जो मूवमेंट्स रिस्ट्रिक्टेड होते हैं, उसकी वजह से उनका स्पीच डेवलप नहीं हो पाता। दूसरा है कि हाइपरनेजलिटी इन स्पीच। तो उनका, हम जो सांस लेते हैं और सांस छोड़ते हैं, तो हम नाक से सांस लेते हैं, मुंह से सांस छोड़ते हैं, लेकिन क्लेफ सॉफ्ट पैलेट में छेद होने की वजह से जो क्लेफ पैलेट का जो पेशेंट होता है या बच्चा होता है, उसका जो सांस है, जो हवा है, वो नाक से ही बाहर निकल जाती है। इसीलिए उसका जो साउंड होता है वो हाइपर नेजलिटी होती है उसके साउंड में, जैसे कि झिंगंग को गया था, इस टाइप में आवाज आती है, क्योंकि वो उसकी मूवमेंट सही नहीं होती और साउंड नेजल निकलता है, क्योंकि नेजल से ही हवा बाहर आती है। मैं गाँव गया था, मैं खाना खाया, इस टाइप में उसका हाइपरनेजालिटी साउंड होती है। उसके बाद हाइपोनेजालिटी इन स्पीच, जैसे कि कोई सूजन है या ये है, तो हमारा आवाज जैसे दबी सी निकलती है, जैसे कुछ वर्ड्स छूट जाते हैं, उसको हाइपरनेजालिटी, वो भी स्पीच में कभी कभी अवेलेबल होती है। कई कई वर्ड्स वो टंग या जो भी वो हिस्सा लग नहीं पाता है, तो वो वर्ड्स छूट जाता है। उसके बाद फाल्टी प्रोनाउंसिएशन। फाल्टी प्रोनाउंसिएशन मतलब उनको र बोलना नहीं आ रहा है, मैं काका की जगह वो कोई और काका बोलना है, तो गाँव, इस तरह से उनका उच्चारण होता है। सो फाल्टी प्रोनाउंसिएशंस। हमने देखा कि अच्छी स्पीच बोलने के लिए हमें क्या क्या ऑर्गन्स और क्या क्या तरीका होना चाहिए। और क्लेफ पैलेट के बच्चों में वो चीज हमने देखा कि भाषा अच्छे तरह बोलने के लिए शब्द के उच्चार स्थान निर्धारित है, उसके बाद वही उच्चारण के सही तरीके होने चाहिए। तो क्लेफ लिप पैलेट बच्चों में फोटो के कारण और टीथ भी नहीं होते, उसके कारण उनका जो त थ द ध है वो ठीक से नहीं बोल पाते, उसका उच्चारण वो नहीं कर पाते। और साथ ही इन बच्चों को क ख ग घ मतलब कंठीय स्वर जो है कि वहां पे जाता है कि टंग का जो पिछला हिस्सा सॉफ्ट पैलेट को लगता है क ख ग घ बोलते हुए, तो वहां छेद होने की वजह से वो चीज भी वो नहीं कर पाते, इसलिए उनका क ख ग घ जो व्यंजन है वो निकाल नहीं पाते। इसी तरह ट ठ ड ढ के लिए टंग ऊपर सॉफ्ट पैलेट में गोल होके लगती है ट ठ ड ढ, तो सॉफ्ट पैलेट में भी दिक्कत होने की वजह से वो ये वर्ड्स भी नहीं उच्चारण उनके लिए उच्चारण मुश्किल होता है। और सबसे मेनली उनका हवा का प्रेशर बिल्डअप नहीं हो पाने की वजह से स और श यह व्यंजन वो बोल ही नहीं पाते, तो बिल्कुल नहीं कर पाते। म और न उनका जो व्यंजन है वो बहुत अच्छे से उनका उच्चारण होता है, क्योंकि वो नेजल है और उनका जो सांस लेना है नाक से लेना और नाक से छोड़ना है, इसलिए म और न उनका बहुत ही क्लियर रहता है। बाकी उनका जो प फ ब भ है, क ख ग घ है, ट ठ ड ढ है, स और श ये व्यंजन वो बोल नहीं पाते। ठीक है, अब हम लोग देखते हैं कि द मेन गोल टू हेल्प चिल्ड्रन विद क्लेफ पैलेट, establish correct articulation, placement, manner and voice using articulation therapy technique। तो नई नई मतलब अलग अलग जो आर्टिकुलेशन थेरेपी टेक्निक्स यूज करके हमको इसका जो उपयोग करना है वो निश्चित करना है, उसके बाद उसका तरीका निश्चित करना है और वॉइस करेक्ट करनी है, क्योंकि उनका हाइपरनेजल साउंड निकलता है, तो उनको हमको उस आवाज को सही करने का गोल हमारे सामने होता है कि सबसे पहले ये चीज हम करते हैं स्पीच थेरेपी के लिए कि पहले उसका आवाज ठीक करना है, उसका स्थान निश्चित करना है, और इसके लिए बहुत सारी अलग अलग टेक्निक्स यूज करनी है, जैसे प्ले थेरेपी हुआ, उनको मिरर थेरेपी से, वो आगे मैं बताऊंगी। उसके बाद है इंश्योर देयर इज गुड ओरल प्रेशर ड्यूरिंग साउंड प्रोडक्शन। ये सुनिश्चित करना है बोलते वक्त कि उसका ओरल प्रेशर सही है, ताकि उसका जो शब्द उच्चारण है वो सही हो। फिर तीसरा है कि द establish new motor speech patterns that replace speech sound errors। तो स्पीच साउंड एरर्स के लिए हमको कोशिश करनी है कि उसको जो रिस्ट्रिक्शंस होते हैं बोलने के जो मोटर्स, कि जैसे कि उसका सर्जरी हुआ है लेकिन उसको जो आदत है कि उसको पता नहीं है कि टंग कहाँ लगानी है, मुंह को कैसे खोलना है, कौन से वर्ड के लिए कितना मुंह को खोलना है, कितना बंद रखना है और कहाँ से अटकाव करना है, तो हमको वो नई टेक्निक्स से उसको उसका मोटर रिप्लेस करके उसका एरर ना आए, इसलिए हमको एक नया तरीका उसको बता के उसको स्थापित करना है कि भैया ये यहाँ पे लगाना है, मुंह कैसे खोलना है, टंग कितने देर तक तुमको होल्ड करके रखना है, इस चीज से उसको रिप्लेस करना है। फिर रिड्यूस हाइपरनेजली, तो हाइपरनेजलिटी रिड्यूस करने के लिए कुछ टेक्निक्स यूज करने हैं, जैसे कि हाइपरनेजलिटी है तो हमको वो साउंड गलत कैसे है और सही साउंड कौन सा है, ये दो साउंड में फर्क दिखाने के अलग अलग एक्टिविटीज लेनी है। जैसे सा रे ग म प ध नी सा, इस टाइम हम लोग कि सा रे, तो रे ऊपर जा रहा है, नी, फिर म क, ये जो साउंड है, ये जो नॉर्मल साउंड उसको बताना है, और हाइपरनेजलिटी कम करने के लिए अलग अलग एक्सरसाइज देने हैं। उसके बाद है टू इम्प्रूव ओवरऑल स्पीच, तो उसका ओवरऑल उसकी स्पीच इम्प्रूव करने का टारगेट होता है, गोल होता है कि भैया उसको कहाँ कहाँ कैसे, हर किसी को सेम प्रॉब्लम नहीं होते, किसी को प फ ब भ आ जाता है, क ख ग घ नहीं आता है, किसी को त का उच्चारण आ जाता है, फ नहीं आता है, तो उस हिसाब से उसके वर्ड्स कौन से वो स्पीच किट द्वारा पहले इवेल्युएशन करने के बाद हमको वो वर्ड को कैसे सिखाना है और प्रोड्यूस करना है, इसका ये गोल हमारे सामने होता है। फिर सबसे महत्वपूर्ण उसमें ये भी है कि पेरेंट्स काउंसलिंग एंड गाइडेंस करना है कि उनके बच्चे को क्या दिक्कत है। कई बार होता है कि भाई पेरेंट्स एक्सेप्ट कर लेते कि लिप कट है, भाई खाना खा रहा है, खेल रहा है बच्चा, ठीक है। बहुत बार स्पीच के बारे में या उसके सर्जरी के बारे में पेरेंट्स को इतना अवेयरनेस नहीं होता, तो उनको काउंसलिंग करना बहुत जरूरी होता है कि भाई कई बार पेशेंट कई दूर से आते हैं कि उसको होम थेरेपी के लिए उनको एक्सरसाइज घर पे कैसे करे, जैसे प्रैक्टिस के लिए, तो उसके लिए भी गाइडेंस करना है कि ये कितना महत्वपूर्ण है कि उनको एक्सरसाइज करने हैं और किस तरह बच्चे से करवाने हैं। अब बिठाए और एक्सरसाइज दिए तो हर बच्चा का कभी मूड नहीं रहता, कभी नहीं करता, तो उसको प्ले थेरेपी द्वारा या उसके साथ कैसे किस तरह से इंटरेक्ट करके उसको जो हमारे एक्सरसाइजेस है वो कैसे करवाए, ये भी हमको पेरेंट्स को काउंसलिंग करना पड़ता है, ताकि वो घर पे अच्छी तरह से बच्चे का स्पीच डेवलपमेंट के लिए बेसिक जो है कि एक्सरसाइज करवाए, ताकि वो स्पीच के लिए यहाँ आए, तो उसको एटलीस्ट उसका जो एक्सरसाइज है वो पूरी हो और हम स्पीच का आगे का हिस्सा फिर उसका नेक्स्ट सेशन में ले सके। अब टाइप ऑफ एक्सरसाइजेस, इसमें एक्सरसाइजेस अलग अलग है। जैसे ब्रीदिंग एक्सरसाइज, ये मेन हिस्सा है कि ब्रीदिंग एक्सरसाइज हम उनको देना बहुत और बहुत जरूरी है। सबसे पहला है कि हम उनको ब्रीदिंग एक्सरसाइज देते हैं कि सांस हमको कैसे लेनी है और कैसे छोड़नी है, क्योंकि हमारा जो बोलना है उसी के बीच होता है। तो ब्रीदिंग एक्सरसाइज में हम नाक से सांस लेना है, मुंह से छोड़ना है। फिर इधर अनुलोम विलोम में हम इधर नाक से सांस लेनी है, फिर 5 या 10 गिनना है, फिर इधर से छोड़नी है। इस तरह के ब्रीदिंग एक्सरसाइज देते हैं। अब बच्चों को अगर ब्रीदिंग एक्सरसाइज समझ में नहीं आ रही कि नाक से सांस ले रहे फिर कैसे, तो उनको पेट पे हाथ रख के हम बताएंगे कि नाक से सांस लेते पेट कैसे फूलता है, फिर सांस छोड़ने के बाद कैसे कम होता है, या उंगलियों का अंतर कम होता है। इस टाइप से अलग अलग टेक्निक यूज करके ब्रीदिंग एक्सरसाइज हम उसको देते हैं। उसके बाद टंग एक्सरसाइज, तो टंग एक्सरसाइज में हम टंग मूवमेंट्स देते हैं कि जैसे 8 मूवमेंट्स है टंग की। बाहर निकालना है, अंदर लेना, ला ला ला, साइड में, ऊपर नीचे, अंदर बाहर, इस तरह टंग मूवमेंट्स की। उसको ऊपर लगाना है, ट सिखाना है, तो हमको वो टंग की मूवमेंट्स बहुत जरूरी है। उसके बाद मिरर एक्सरसाइज, तो ये जो एक्सरसाइज देते हैं कि हमको प्लेस ऑफ आर्टिकुलेशन अगर बताना है, तो उसके लिए हम मिरर दिखा के कि भाई उसको टंग कहाँ रखनी है, कहाँ लगानी है, कहाँ प्रेस करना है, इसके लिए हम मिरर एक्सरसाइज देते हैं। उसके बाद जा एक्सरसाइज के लिए अलग अलग जा एक्सरसाइज देते हैं। उसके बाद बलून ब्लोइंग एक्सरसाइज, बलून फुलाना है, ताकि उसके जा एक्सरसाइज के लिए बलून फुलाने का ये होता है, क्योंकि प फ बोलना है, उसके लिए जा एक्सरसाइज भी बहुत जरूरी है, क्योंकि ये स्ट्रक्चर अगर सही नहीं होगा वाणी का, तो हम भाषा ठीक से नहीं बोल पाएंगे। उसके बाद स्ट्रा एक्सरसाइज है, जिससे स्ट्रा से थर्माकोल के बाल उड़ाना है, या फिर स्ट्रा से हवा फूकना है, बलून बनाना है, इस तरीके से। उसके बाद कैंडल ब्लोइंग एक्सरसाइज, कैंडल ब्लोइंग ऑफ मतलब दूर कैंडल रख के उसको फूक मारना है, जिससे तुम्हारी जा एक्सरसाइज भी होगी और हवा जो प्रेशर बिल्डअप होगा उसके लिए कैंडल ब्लोइंग ऑफ की एक्सरसाइज देते हैं। जैसे कि आप इसमें देख रहे हैं स्ट्रा एक्सरसाइज है, इससे अलग अलग टेक्निक से उनको स्ट्रा एक्सरसाइज करवाते हैं, जिससे उनका हवा का प्रेशर बिल्डअप हो। अब टेक्निक ऑफ हाइपर नेजालिटी, इसमें ये जो है स्टिमुलेबिलिटी प्रोब आता है, जो ट्राई टू गेट चाइल्ड इमीडिएट रेजोनेंस, उसका ध्वनि सही होने के लिए हमें ये प्रोब का यूज होता है कि ध्वनि कैसे निकलता है। जैसे हम यहाँ लगा रहे हैं और उसको ये हवा का ये दे रहे कि उसका जो ध्वनि आ रहा है तो वो कहाँ से आ रहा है, ये उसको समझने के लिए। अल्टरनेटिंग टंग पोजिशन, ट्राई फॉर लोअर पोस्टीरियर टंग प्लेसमेंट। फिर टंग के लिए हम ये कर रहे हैं कि उसका साउंड टंग की अलग अलग पोजीशन देके हाइपरनेजलिटी कैसे कम करे, उसके लिए हम टंग की पोजीशन दे रहे हैं। फिर ओपन माउथ, कि हाउ अ चाइल्ड स्पीक विथ हिज माउथ मोर ओपन, उसके लिए हम जैसे आ होल्ड करके 3 सेकंड होल्ड करके रखना है, फिर आ बोलना है, आ। अब जैसे उसके साउंड है आ, तो फिर यहाँ हाथ रख के आ, ओ, आ, ये हाइपरनेजलिटी साउंड आएगा उसका। तो उसको करेक्ट करने के लिए अलग अलग टेक्निक से हम उसका ये हाइपरनेजलिटी कम करने के लिए इस तरह से सिखाएंगे। ट्राई डिफरेंट वॉल्यूम टू सी विच हैज लेस देन नेजलिटी। नेजलिटी कम करने के लिए उसको अलग अलग साउंड सिखाएंगे, वॉल्यूम चेंज करेंगे। और इसके लिए हम कहीं रेडियो की मदद लेंगे या ओरल वॉइस का मदद लेते हैं कि भैया उसको वॉल्यूम कैसे कम, ये बड़ा है ये छोटा है, ये दिखाने के लिए अलग अलग उससे प्ले थेरेपी भी ले सकते हैं कि दूर से उसको आवाज दे रहे हैं फिर पास से आवाज दे रहे हैं, ये फेंको ये लो। इस टाइप से हम एक्टिविटीज लेकर भी डिफरेंट वॉल्यूम सुनाकर उसको नेजलिटी कम करने के लिए मदद करते हैं।
हाँ माझ्या डॅडची
कुछ वर्ड्स भी कुछ वर्ड्स का एक्सरसाइज भी देते हैं, जैसे डैड, पंखा, पपया, पपया, जींस। वहाँ उसको आर्टिकुलेशन का टंग और इसका प्लेस हम बताते हैं। पप्पू, कुकी, किट्टू, लाल, मीरा, मोहन। फिर कुछ सेंटेंस हैं जैसे पूजा, पूजा टाट वाट, पवन पिक्चर देखो। इस टाइप से हम उसको अलग अलग एक्सरसाइज देते हैं। पापे पी, बाबे बा, ताते ती, टाटे टी, मामी मामा। इस टाइप से उसको जैसे पवन पिक्चर देखता है, पूजा खाना दो, पायल पानी पियो, बाहर बहुत बारिश है, तारा ताला तोड़ो। इस टाइप के मूवमेंट्स के लिए हम उसको वर्ड्स और सेंटेंस करवाते हैं। फॉर इफेक्टिव स्पीच थेरेपी मैं कहना चाहूंगी कि द अर्लियर डायग्नोसिस ऑफ द क्लेफ्ट लिप पैलेट चाइल्ड एंड सर्जरी इज वेरी इंपॉर्टेंट है, क्योंकि बच्चा स्पीच थेरेपी के लिए 0 to 5 years बहुत ही महत्वपूर्ण समय होता है बच्चे का लैंग्वेज डेवलप करने के लिए, क्योंकि उस वक्त उसका ब्रेन बहुत शार्प होता है और कोई भी भाषा, कैसी भी भाषा और जो भी चीज हम उसको सिखाते हैं वो बहुत जल्दी एक्सेप्ट करता है और सीखता है। तो हम लोगों को ये उसका जो पीरियड है 0 to 5, वो हमको अगर उस इसमें अगर सर्जरी होती है तो बहुत बहुत फास्ट उसका स्पीच थेरेपी डेवलप होता है। अब क्ले फ्लिप पैलेट से जुड़े बच्चे को एक सामान्य रूप में प्रस्तुत करना एक्चुअली बेहद जटिल एवं मुश्किल कार्य है। हर बच्चा अपनी अलग अलग समस्या के साथ सामने आता है, बहुत सारे करेक्शन उसमें करने होते हैं। हर बच्चा एक चैलेंज की तरह होता है और उसकी फाइन और सफल सर्जरी के लिए डॉक्टर सर्जन को कड़ी मेहनत और बुद्धि चातुर्य का उपयोग करना होता है। यह एक टीम वर्क है जिसमें हर टीम वर्क को अपने अपने हिस्से के विषय में कुशलता का परिचय देने की आवश्यकता होती है। तो मैं एटलस ऐसे इतना ही कहना चाहूंगी कि स्पीच थेरेपी जो है वो बहुत महत्वपूर्ण हिस्सा है। मतलब इसका क्लेव पैलेट, आफ्टर क्लेव पैलेट अगर स्पीच थेरेपी ना हो तो बच्चे की इतनी सारी मेहनत जो डॉक्टर्स करते हैं, सर्जरी करते हैं, इतनी सारी मेहनत करते हैं, तो उसका स्पीच अगर डेवलप नहीं होता है तो उनकी मेहनत कहीं ना कहीं बेकार जाने का अंदेशा होता है। तो अगर क्लेव पैलेट सर्जरी होती है तो स्पीच देना बहुत जरूरी। बहुत बार ऐसा होता है कि पेरेंट्स को लगता है कि भैया उसका होठ कटा था और अब ठीक हो गया है तो अभी कोई जरूरत नहीं है, या हो गया भाई बच्चा ठीक हो गया घर लेके जाओ। स्पीच थेरेपी के बारे में कई बार लोग अवेयरनेस नहीं हो पाता। तो वो बहुत जरूरी है अवेयरनेस की भाई स्पीच थेरेपी ये इसका छोटा ही सही लेकिन हिस्सा है। क्लेफ आफ्टर क्लेफ पैलेट स्पीच थेरेपी देना बहुत जरूरी है और इसके लिए पेरेंट्स काउंसलिंग भी जरूरी है कि वो स्पीच थेरेपिस्ट के पास पहुंचे और ये चीज करवा ले। लास्ट में यही वही कि फॉर बेटर आउटकम कैच देम, कम्युनिकेशन is a very effective medium of self expression, तो express yourself with beautiful words। Thank you.
Thank you, ma'am, for the informative lecture and taking our attention to the less well-developed speech therapy consideration for an interdisciplinary treatment approach for CLP patients. I may now request Dr. Atin sir to kindly present you the certificate.
Thank you.
Thank you, ma'am.
Thank you.
Moving forward, we have seen the management protocol for cleft lip and palate
Hello.
patients in the face of. Yes, sir.
सॉरी मैं म्यूट था. मैं थैंक यू कहना चाहता हूँ. इट वाज अ वेरी इंफॉर्मेटिव लेक्चर. आपने सिंपल लैंग्वेज में समझाया मैडम काफी अच्छे से, और बहुत ही जरूरी होता है. इट इज और निग्लेक्टेड टॉपिक डेफिनेटली. स्पीच थेरेपिस्ट हर इंस्टीट्यूट में नहीं होते हैं, तो बाहर भेजना पड़ता है हर काफी लोगों को, एंड बच्चों को फिर वहां लेके जाना पेरेंट्स को भी बहुत डिफिकल्ट लगता है, क्योंकि एक ही इंस्टीट्यूट में अगर सारी 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 फैसिलिटीज मिल जाए तो वो बहुत अच्छी मतलब बहुत अच्छी बात होती है पेरेंट्स के लिए भी. तो आपका बहुत बहुत धन्यवाद. थैंक यू मैडम.
Thank you so much.
सर्टिफिकेट प्लीज सर्टिफिकेट एक्सेप्ट कीजिए. थैंक यू सो मच.
Okay, thank you, sir.
Moving forward, we have seen the management protocol for cleft lip and palate patients in the face of psychological implications as a pediatric dentist and as a speech therapist. Now, let's see the role of a prosthodontist in prosthodontic rehabilitation for the management of CLP patients. May I now introduce and call upon Dr. Tushar Movade, sir, to deliver his lecture. Dr. Tushar Movade completed his BDS from Sharad Pawar Dental College, Wardha, and went on to pursue his master's from GDC Aurangabad. He is a PhD scholar from MUHS Nashik. Sir has a working experience of 16 years in total, and he has been enlightening the paths of PGs by being a PG guide for 10 years. He is also credited with a patent and copyright of implant abutment connection design. He also has been an active member in conducting various conferences and conventions, has various posters and paper presentations to his credit, along with it many international and national publications to his name. He has been seated as a judge at various scientific sessions. He has been continuing his deeds in the academic field by attending various workshops and also conducting guest lectures himself. He is also a gritty trekker and has successfully completed various trekking expeditions. Over to you, sir.
Very good morning to one and all. Myself, Dr. Tushar Mohade. I will be presenting before you the role of prosthodontics in management of cleft cases. Before I start with my presentation, first of all I would like to thank to the Chhattisgarh Dental College and Research Institute, Rajnandgaon, and special thanks to Dr. Invited me to this symposium on the comprehensive management of cleft lip and the palate. So let us begin with the presentation. As you all know, cleft palate is the most common amongst congenital malformation. It is almost occurring in the 1 in the 800 births. If we see the GPT definition, cleft is a space or opening made through splitting. Right? So the palate, hard palate and soft palate premaxilla is splitted. Left and right parts do not fuse, then the cleft occurs. So the plight of these patients in society is very difficult to understand, as because they feel socially isolated. And as a prosthodontist, we need to rehabilitate these patients functionally as well as socially. when we talk about the treatment of the cleft palate, it is not a job of one person. It's a team approach. So the team of the management of these cleft cases includes plastic surgeon, speech therapist, ENT surgeon, psychiatrist, orthodontist, oral surgeon, and the prosthodontist. This is just a slide to show the anatomy of the palate, where the premaxilla and the maxillary processes, frontonasal process, they fuse and form the complete palate. And when there is no fusion, there is a formation of the cleft. When we talk about the treatment, and if we see the treatment protocol of cleft lip and the palate, as always, as a physician, we know that examination, diagnosis, and the treatment planning should precede before we start actually with the management. So that should be done in these cases also. Then next come is the surgical management and orthodontic management, and then is the prosthodontic management. So these will be the heads under which I will be covering the prosthodontic management of cleft palate and lip cases. So first thing we will see will be the nasoalveolar molding, then the maxillary orthopedics, then speech appliances, different speech appliances, pharyngeal obturator, hard palate obturator, entry prosthesis. Then for adults, fixed and different fixed and removable prosthesis. Then what is the role of implant in this, and how in the management of cleft cases, and how is the digital workflow for the prosthesis fabrication for this type of the cases. So these will be the heads we will see under which the prosthetic management will see. Now in the diagnosis and treatment planning, so examination, patient's personal history, general case history, dental history, impressions of the study cast for the study cast, radiographs, photographs, speech recordings, measurement of nasal and oral pressure and flow, then otologic and hearing examinations, psychological and social considerations in these patients. So all these points should be seen under the history examination and the diagnosis for the diagnosis. Now, after we come to the diagnosis, when we plan our treatment, this is a chart showing the timeline of the different treatment options. It can be of all the disciplines in the management team. So this is the timeline from birth to the ninth month. Palatal obturator we always have to provide. Then cleft lip is operated around the third month. Soft palate and hard palate management, surgical managements are carried out during around 9 months to the 12 month. Then speech therapy is needed to these patients during the third year to the sixth year. Then bone grafting procedure, if any needed, has to be carried out during the ninth year to the 11th year. And orthodontic management comes in the three phases. First phase between the third year to the sixth year or fifth year, and in the mixed dentition phase around seventh year, and in the later in the adulthood to complete the aesthetic and other managements of the orthodontic orthodontic treatment. And then at the end, further cosmetic corrections and prosthodontic management has to be carried out if the patients are done with until the orthodontic management. Right? So remaining corrections are done prosthetically. So if we see the surgical management, there is already a lecture in the surgical management. So we will not take this in much detail. So we follow the rule of 10 when the patient is of 10 pounds, hemoglobin is 10 grams, and is at least of 10 weeks of age, then the surgical management is done. So that's a different topic. Then the orthodontic management also, it is done in three phases. When the patient is between the age of 3 to 5 years, phase 1 is there. When the eruption of full component of deciduous molar is there, and early posterior segment alignment is done, that is the maxillary orthopedic is done between this phase 1. In the phase 2, between 5 to 7 years, posterior anterior segment alignment is done, and in early mixed dentition or in the late primary dentition phase. And in the phase 3, complete orthodontic, treatment of open bite, arch length, negative physis, narrow constricted palate. So that is the complete orthodontic treatment is done when the patient come closer to the adult. Okay, so after the completion of the orthodontic phase, next come is the prosthodontic management. So this is the main core component of our presentation. This prosthodontic management is carried out in the three parts. First is the nasoalveolar molding, and which is carried out in the early phase of the treatment. Then maxillary orthopedics, when it is needed, it is carried out in the middle phase of the treatment, and the remaining things are carried out when the patient is mature, well prosthetic or in the to improve the functional performance of the patient, that is the prosthetic speech appliances. Now, in the first, that is the nasoalveolar molding. The basic treatment objective for the cleft lip, alveolus, and the palate patient is to restore the normal anatomy. Now, this includes the nasal component as well, because of the major hard and soft tissue abnormalities observed in this patient. It is highly desirable to restore the correct skeletal, cartilaginous, and soft tissue relationships pre-surgically. In case of the bilateral deformity, it is advantageous to lengthen the deficient columella prior to the primary surgical repair of lip and the nose. So when the patient is in the developing stage, in the early stage of the treatment of the cleft palate and lip patients, we can mold the cartilage because they are still developing. And it is proven in many studies that we can carry out the nasoalveolar molding to change the growth of our cartilage. So that is why, that is what the basis of nasoalveolar molding is, that we can direct the growth of the nasal cartilages to the way we want to direct it. Now, objective of the nasoalveolar molding is active molding and repositioning of the deformed nasal cartilage and alveolar process, and lengthening of the deficient columella. So, in many cases where the wide cleft is there, bilateral cleft is there, this columella is deficient, and we need to lengthen it and bring it between the two half of the two parts of the cleft, so that the closure becomes more, we can close it in a more better way, and predictable closure can be achieved, so that all the segments come close to each other, left and right segments, and the cartilage also grow downwards to bring the closure more effectively surgically. Now the correction of now this we will see nasoalveolar molding will see in two parts. First is the correction of unilateral oronasal cleft deformity, and second as a bilateral how to do nasoalveolar molding in bilateral oronasal cleft deformity. When we treat the unilateral oronasal cleft deformity, it is carried out at first to second weeks after birth. The infant is evaluated by the member of interdisciplinary cleft team, right? So you can see the unilateral cleft deformity, and then the impression, once it is planned that nasoalveolar molding is required, the impression procedure is started. And these impressions of the infant, whenever we have to carry out, we have to carry out these impression procedures in hospital setup, because if there is an emergency of airway emergency, all the facilities are available in the hospital setups. So it is better to carry out these impression procedures in the hospital setups. We can use the infant impression tray or your fingers to make the impressions. So whenever we are making the impressions, we have to put the patient in the prone position like this, and then carry out the impression. Now, once we get the impression, and before the impression to get a cast, we can make a conventional molding plate with the clear acrylic, and you can then finish and polish that conventional molding plate. Now, in this conventional molding plate, when we give to the patient, it has to be modified weekly so that we can apply forces in the desired direction to carry out the molding. Now, here you can see the red areas. Now, this is the area of the plate where we need to add the material. Permasoft soft liner can be added in these areas, and while adding the material here, we have to at the same time remove the acrylic from the inner side. So that force is applied from this direction, and this segment moves inward, and these two segments come close to each other. Right. So this is how the modifications in the plate are carried out. Right. Here also, this segment is removed from inside and a hard acrylic added from the outside, right? So that these two segments come close to each other and surgical closure becomes more predictable. So that is what the purpose of this management of unilateral cleft with the nasoalveolar molding is. So these modifications has to be carried out weekly. Then extraoral retentive button we have to add here. The purpose of this retentive button is to hold this nasoalveolar molding plate into the oral cavity, giving a constant pressure upward and backward. And that is what the purpose of this retentive button is. So we have to first apply a larger tape on the cheeks in this direction, right, on the both the side, and then the smaller tape is sticked to the retentive button, and with the help of orthodontic bands also, elastics also, we can tie this plate to this thicker tape we have already applied on the cheeks with the help of second tape, which is a narrow and orthodontic elastics, so that a constant pressure is applied in this direction, that is the upwards and the posterior directions, so that when we do the modification every time, this constant force when the patient is wearing this nasoalveolar molding plate moves this segment close to each other, right, to fulfill the purpose of our nasoalveolar molding. Now, when the alveolar cleft width has been reduced to less than 6 millimeters, right? So initially we have given the plate, the alveolar segments has come close to each other, and when they come close to each other less than the 6 millimeter, nasal stent may be added to the molding plate appliance to begin the nasal cartilage molding. And now we can start the nasal cartilage molding when the two parts of alveolar process come close to each other less than 6 millimeter. Now nasal stent is a projection of acrylic that is fabricated on the labial flange of the oral molding plate. You can see in this picture. So this is the nasal stent. This part is a nasal stent. We can fabricate it in the acrylic also. We can fabricate it in the acrylic and attach it to the plate with the help of wire. It is better to attach it to the plate with the help of wire, because we can add the tension, reduce the tension when we use the wire to attach this nasal stent to the prosthesis. Now, when we place this plate into the oral cavity and we put this nasal stent into the patient's nostril. Now this will be activated by bending a little bit towards the outer side, the wire to the outer side, and when we bend it little bit to the outer side, wire to the outer side, it will apply force in this direction, so that the cartilage which is having a growth in this direction will be redirected to the center, so that the cartilage growth is modified. And when we use these buttons, nasal buttons, right, the patient's anatomy of the nostril is modified, and that is what we need with the help of this nasal stents, right? So the nostril is and the cartilage is redirected, growth of the cartilage is redirected, and it is redirected in the desired direction, right? And once this is achieved, then the surgical management is carried out, so that the lip closure become more predictable and accurate. Now we come to the correcting bilateral oronasal cleft deformity. In the complete bilateral cleft, the premaxilla is suspended from the tip of the nasal septum, whereas the lateral alveolar segments remain behind. Right? Premaxilla is suspended in the center, and lateral alveolar segments they remain behind. An objective in the management of bilateral cleft patient is to lengthen the columella. So primary objective, an important objective is lengthening of the columella. So bringing the columella down and forward is the objective. To reposition the apex of alar cartilage towards the tip of the nose, to align the alveolar segment and premaxilla to form the normal maxillary arch. In the intraoral molding plate, the intraoral molding plate is fabricated that encompasses the lateral alveolar segment and premaxilla, and the two retentive buttons are fabricated. It is similar to the procedure we followed for the management of making the nasoalveolar plate for the unilateral care. So impression is done in the same way, and the plate is fabricated, right, with the two retentive buttons. There was only one retentive button. Now here we will fabricate two retentive buttons. That plate is now placed intraorally, right, and the elastic bands are applied. First is the large elastic band, then the smaller elastic band, and the orthodontic elastics are tied here, the smaller elastic band, so that the force is applied in the posterior direction. So this is how this placed in plate. The first stage of treatment includes repositioning of everted premaxilla into the space between lateral alveolar segments. This is accomplished through progressive modification of acrylic intraoral molding plate. Now, the portion of the acrylic plate that contains premaxilla is modified by adding hard and soft acrylic resin anterior to the premaxilla, whereas the hard acrylic resin is removed from the region behind it. You can see here the portion which is added on the outside, and from the inner side, right, it is removed, so that this premaxillary component and this posterior component comes close to each other, right? The ultimate objective of the sequential addition and selective removal of material from the premaxillary portion of molding plate is to retract the premaxilla, so that these three segments come close to each other and facilitate the surgical closure. Now, nasal stent also can be added here in the bilateral cleft. So these are the nasal stent, and it is better to add these nasal stents with the fire. In the second stage, after approximately 3 weeks of the treatment, a pair of nasal stent is built up from the anterior flange of the molding plate to enter the nasal apertures. The nasal stents elevate the nasal cartilage and provide resistance to downward pull by the tip placed on the prolabia, right? Then the tip of the nasal stents are bifid and they are divided into the two lobes. They are bifid and divided into the two lobes. The superior lobe enters the nostril and exerts anterior force under the nasal tip. The lower lobe of the nasal stent is positioned under the apex of the nostril aperture and pressing up against the soft triangle, right? Pressing up against the soft triangle. The attached across the two nasal stent is the horizontal prolabial band. You can see here, this is the prolabial band, right? This is the prolabial band. So it is attached across the two nasal stent, right? This band depresses the columella base in the region normally represented by lip columella junction. So this is the lip columella junction, and this prolabial band this prolabial band depresses the columella base, right? And it provides the additional lengthening effect to the columella, right? So because of this prolabial band, columella is pushed downward, right? So it provides the lengthening effect to the columella. Now this was about the nasoalveolar molding. Now this nasoalveolar molding has to be carried out uh, uh, when we are managing the cleft lip, cleft lip and palate in the early stages, right? But when the patient becomes mature, now the nasoalveolar molding cannot be carried out, right? So that time we have to carry out the maxillary orthopedics. Now it is proposed that the maxillary orthopedic is proposed to stimulate the growth of tissues to obtain the closure of the palatal defects without surgical intervention. Now the different indications for prosthesis in unoperated cases, unoperated palates for the maxillary orthopedics, when there is a wide cleft with deficient soft palate, wide cleft of hard palate, combined prosthesis and orthodontic appliance when needed, expansion prosthesis to improve the spatial relationships of the alveolar process and the premaxilla, then neuromuscular deficiency of soft palate and the pharynx. So these are the indications for the prosthesis in unoperated plates. And indications for prosthesis in operated plates, an incompetent palatopharyngeal mechanism is there. Whenever there is a palatopharyngeal incompetency, there we can give the maxillary orthopedics and surgical failure. Now the objective of maxillary orthopedics. In case of wide unilateral or bilateral cleft, and where the chiloplastic is difficult because it will result in excessive tension on the surgical side, pre-surgical orthopedics can be carried out so that there is a normal bony anatomy and it allows more ideal lip closure. If untreated, these type of patients are untreated, the lateral alveolar segments usually collapse, and which leads to the malalignment of these segments. With early orthopedic intervention, we can avoid that. These maxillary segments aligned to a more anatomically correct position and resulting in better alignment of the parts. Now, what are the different orthopedic appliances which we use? One is the passive or holding appliance, and the other is active or expansion appliance. Now, holding appliance is used in cases presenting initially with an ideal arch alignment, but with a wide cleft to avoid the collapse. So when there is ideal arch alignment, we are giving the holding or the passive appliances. And expansion appliance, if any degree of collapse is already manifested, guide the maxillary segment into the proper spatial position with each other and with the mandibular arch, we give the expansion appliance. So after good alignment is achieved, lip continuity can be restored. So this is the indication of expansion of appliance when there is a collapse already, and we need the alignment of the all the three portions. Now next comes in the prosthetic management is prosthetic speech appliances. Now these prosthetic speech appliances can be fabricated for the children and also for the adults. For children, there are three types of speech aids which can be constructed. First is the pharyngeal obturator and palatal lip prosthesis. Palatal plate type, which functions to obturate the palate and help speech, and anterior prosthesis, which contours and improves the anterior occlusion. Now first we'll see the pharyngeal obturator and the palatal lip prosthesis. The pharyngeal obturator prosthesis does not replace the soft palate, but replaces the missing portion of the soft palate. They are typically short-term prostheses used in order to close the defects of the hard and soft palates that may affect the speech production or cause nasal regurgitation during the feeding. The prosthesis will elevate the soft palate and obturate the palatopharyngeal gap, thereby simulating the palatopharyngeal activity and pharyngeal muscle contraction. So this is, you can see the picture, this is the defect and this is the pharyngeal obturator, obturating the defect and providing closure in the soft palate and some part of hard palate and during the different movements also, so that the functions of the patients can be carried out. Then the palatal lip prosthesis, it is especially useful for the patients with insufficient palatopharyngeal competence who exhibit compromised motor control of soft palate and related muscles. It is used to elevate the soft palate to its maximum desirable position during normal speech and deglutition, enabling closure by pharyngeal action. Now, this you can see in this picture. This is the anatomically normal but paralyzed soft palate, functionally insufficient, and you can see the palatal lip prosthesis placed in position so that it lifts the soft palate and it brings the palatopharyngeal competence which is required during the function. Now, second type of the prosthesis which can be given to the patient is a simple palatal plate type, which functions to obturate the palate and helps the speech. And the third type of the prosthesis is the anterior prosthesis. Mandibular prognathism is seen between 9 to 14 years without comparable growth of the maxilla. So it looks like a maxillary growth is hampered and mandible become prognathing. The anterior prosthesis helps to restore the function with mandibular dentition and create a pleasing profile. So aesthetic can be improved by providing the anterior prosthesis and which rebuilds the needed arch form. Now, how we manage the prosthesis for the adults? That was all about the managing children. Now we can the adult we can be managed with the help of fixed prosthesis, fixed removable prosthesis, or the removable prosthesis. In the fixed prosthesis, when there is a ridge defect which is small, fixed partial denture can be given to supporting the lip so that aesthetics is restored and function is restored. Then we can also manage some cases where there is more deficiency of the premaxilla with the help of Andrews bridge type of the prosthesis, which is a fixed removable type of prosthesis. The copings are given on the adjacent tool and the bar is fabricated and over which there is a removable prosthesis. You can add the acrylic to that removable prosthesis to provide the proper lip support so that aesthetic is also restored. So this is the another prosthesis, anterior prosthesis, which we can give in the adults, Andrews bridge type, fixed removable prosthesis. Then the removable prosthesis also we can fabricate. Removable cast partial dentures can be fabricated as a definitive prosthesis to close the palatal and velopharyngeal defect. Precision attachments can be used here to improve the retention. Additional acrylic can also be added in these removable prosthesis to give the lip fullness and create the normal aesthetics. Now we come to the implant as a retentive aid in the management of the cleft. Implants can be used whenever possible when the condition is favorable for the placement of the implant. The osseointegrated implants may assist in retention, stability, and support of the alveolar prosthesis. The mastication is significantly improved if we provide the implant supported prosthesis, and speech is also improved, swallowing is also improved, and it becomes more efficient. Thus, the adaptation to the prosthesis becomes much easier to the patient. And now, as the world is becoming digital day by day, we should also know what are the digital workflow for the management of cleft. Also, the digital workflow is similar to the digital workflow for the other digital type of prosthesis. We need to have a CT scan images of the patient, CT scan of the patient. Then we have to do the intraoral scanning of the patient, and these two images are overlapped, and then the prosthesis is designed in the computer, and that design prosthesis can be milled. This is the design prosthesis. This design prosthesis can be milled to get a actual prosthesis, and this prosthesis can be delivered to the patient, or it can be modified in the defect area by relining, and then delivered to the patient. So this was all about the different prosthetic management part of the cleft lip and the cleft palate patient. So to conclude, the patient with cleft of the palate presents a complex biological, social, logical, and psychological problem. We can manage them in best possible way by involving the several disciplines. So it is not a job of one discipline; it has to be a management by a multidisciplinary approach. The team approach is the only effective one, with members usually including pediatrician, plastic surgeon, pedodontics, otolaryngologist, orthodontist, speech pathologist, prosthodontist, geneticist, pediatric psychiatrist, and the social worker. So it's a team approach and can be managed only by including all the fraternity. So that is the end of my presentation. I would again like to thank to the Chhattisgarh Dental College for inviting me to their symposium on the cleft lip and the palate. So thank you one and all for the patient here.
It was a pleasure to attend to your lecture, sir. Thank you so much for sharing your immense knowledge and such efficiently explaining the necessary details of pre-surgical nasoalveolar molding, maxillary orthopedics, and prosthetic speech appliances. May I now request Dr. Achin sir to present sir with the certificate.
Sir, good afternoon. Thank you so much.
Achin, thank you.
It's good to see you after a long time, sir.
हाँ Achin, अच्छा लगा आपको भी देख के. Thank you for inviting Achin. You and
yeah, thank you, sir.
Dr.
Shailendra Sahu, sir.
हाँ.
Thank you. It was a very good, nice, informative lecture, sir. आपने काफी सारा डिटेल एक छोटे से लेक्चर में समझाया. Thank you so much.
Thank you.
Kindly
Thank you.
accept the certificate for appreciation. Thank you, sir. Thank you so much.
My pleasure. Thank you, Achin. Okay.
I now request Dr. Rizwan Gilani sir to come forward for the next lecture on retention protocol in cleft lip and palate. Dr. Gilani sir has completed his graduation and post-graduation from Rajiv Gandhi University of Health Sciences, Bangalore. He has fellowship in cleft orthodontics from DMI-MS, Vardha. He is a rank holder in Rajiv Gandhi University of Health Sciences, Karnataka for the MDS examinations held in 2014. He has been awarded a certificate of appreciation and a cash prize from the Islamia Urban Cooperative Credit Society and at Yavatmal for securing the highest percentage marks in postgraduate examination. He is currently working as assistant professor in Sharad Pawar Dental College, Datamege Institute of Medical Sciences, Savangi, Vardha, and as a consultant orthodontist in numerous private clinics and hospitals in Yavatmal, Vardha, Nagpur, Durg, and even Kolhapur. He is credited with numerous publications in national and international scientific journals. Sir, please proceed.
I request everyone to please be patient. We are working on the issue.
Meanwhile, let's try and solve these riddles. The participants can post their answers in the chat box. Dr. Ayush seems to be the most intellectual here. We've also got answers from Dr. Abhishek Banerjee and Dr. Megha Jain, ma'am. I'm afraid to say that Dr. Ayush and Dr. Piyush sir, your answers are wrong. I will disclose the answers in the end. Yes, Mount Rushmore is the right answer. Now, this one is the easiest. I expect most answers for this one. Yes, exactly. The answer is short. Yes, Dr. Ayush, you are close, but I think you need to try a little more. A hint here, it is not related to a ball. Yes, exactly. We have got the right answer. Dr. Abhishek, it is anchor.
Hello. Am I audible?
Yes, sir, you are audible.
Okay. Shall we start?
Yes, sir, please proceed.
Yes.
Okay. I apologize for the technical glitch, but I think that is a part of the online symposiums. Anyways, thank you, Ayushi, for that warm introduction. And it is always a pleasure to have it from your ex-student. So before I begin with the presentation, I would like to thank the organizers led by Mr. Nemichand Parak, the president of the institute, Dr. Hema Suryavanshi, ma'am, Dean, CDCRI Rajnandgaon, Dr. Achin Chachada, HOD and organizing secretary for today's event, Dr. Megha Jain, the scientific convener, Dr. Piyush Khandelwal, Dr. Tanusha, Dr. Sonam, Dr. Jyoti, and all the organizers of this symposium on cleft lip and palate. So after the brainstorming sessions by the stalwarts in the cleft lip and palate care, I would like to start my topic, which is the retention protocol in cleft, a strive to seal the heel. So before I begin with the formal presentation, this is where I come from, the Department of Orthodontics and Dentofacial Orthopedics, SPDC, Savangi Meghe, Wardha. And this is our hospital, Acharya Vinoba Bhave Rural Hospital, which is collaborated and associated with the Smile Train USA, which is the organization providing the cleft care throughout the world. So before I begin with the retention and the retention protocol in cleft lip and palate cases, I would like to just introduce the topic with the basics about retention. So retention, as we all know, is maintaining the newly moved teeth in position long enough to aid in the stabilization and correction. So this is the definition of retention that we all usually follow when we are treating our cases orthodontically. And this is always aim of the orthodontist, that whatever corrections he has achieved should also remain and remain stable throughout life as far as possible. But when we talk about retention in cleft patients, it is something where it is a neglected aspect, thinking that it is not orthodontics, or it is not important to retain because finally the patient will undergo a surgery, and the surgery itself will retain whatever you have achieved, but it is not like that. Special care and special importance should be given to the retention in cleft patients, because unlike our normal orthodontic patients, treating cleft patients itself is a challenge. And once you have achieved, or once you have overcome that challenge and you have treated a patient with cleft, the next important thing is to retain whatever you have corrected. So retention, as we all know, are of three types, that is natural or no retention, limited or short-term retention, and prolonged retention. So when we talk about the retention protocols in cleft, it is the prolonged or permanent retention that we will be dealing with, because the corrections that we do are drastic, and the corrections that we do are drastic, and retaining them has to be a lifelong retention or a permanent retention that should be followed. As we all know, relapse is any correction achieved by orthodontic treatment, and there are different causes of relapse, starting from the severe amount of fibrosis of tissue in the lip, palate, and alveolus. These are the causes of relapse in the cleft patients, unlike our normal orthodontics alone, where it is mostly due to the periodontal ligament traction or the fiber contraction. When we talk about the relapse cases or relapse causes in cleft patients, it is the severe amount of fibrosis tissue in the lip, palate, or the alveolus. Also the periodontal ligament traction, whenever we move the teeth, whatever are there. The less availability of bone, because there is a big defect which is lying in the anterior portion, or sometimes extending till the uvula of the palate. So there is a lot of shortage of bone that is available to do the correction as well as retain the correction. Then also there are some growth related changes, because the cleft care is started as early as the first month of the birth of the child, and it continues till the child gets adult, and maybe till the age of 20-25 years, till they get their prosthetic surgeries done. Also the bone adaptation is a challenge, because the calcification of the osteoid bone is less stable. So that is another challenge, or that is another cause for relapse in cleft cases. Then of course the muscular forces, the carious teeth, the persistence of etiology, the third molar eruption, and irregular and delayed appointments by the patient, because there is a lot of patient burnout. The patients and the parents get tired of visiting the clinic starting from the birth, and every month they have to come for the follow-up. So that is another reason that many a times the corrections that are done relapse back. So whenever we talk about the retention in cleft lip and palate, high consideration should be given for retention in cleft lip and palate cases. In fact, more consideration than the orthodontic treatment should be given in these cases. And the reason is, it is not only teeth that you are supposed to retain, but also the corrected lip, the corrected palate, and the musculature that you are correcting over a period of time, that needs to be retained. So drooping down of the mesial cura of the cleft side of the nostril post pre-surgical nasoalveolar molding is something that should be retained properly. Open bite, which is usually seen in unilateral cleft lip and palate cases, because of which there is upward tipping of the alveolar segment, and after due to the approximation of the lip repair also, when we apply the force transversely, we see a small amount of anterior open bite that is evident. And as we all know that it is difficult to retain open bite. So that special consideration also has to be taken into account. Also, there is severe tipping of the posterior teeth for arch coordination. Many times when the patient comes to us, the arch or the maxilla is already collapsed and there is severe constriction. And in order to have that coordination of the maxillary and the mandibular arches, we just go on expanding, expanding, and expanding. And because of which we achieve the good amount of expansion, but that leads to the severe tipping of the posterior teeth, which again becomes a challenge to retain. Also, there is a failure of implant prosthesis in the grafted bone many a times, which is the reason that has to be given important consideration for retention. Many a times the defect is so big that the alveolar bone grafting that is done in the defect fails. So the retention is not only important for the teeth and the bone and the musculature, but also for the bone grafting that is done, that has to be properly retained. And especially the class 3 skeletal pattern which develops in the patient of cleft lip and palate is a challenge to retain. So these are the reasons that high consideration should be given to the retention factor in cleft lip and palate cases. Yes, treatment of cleft lip and palate is something which is very difficult to achieve, but once the treatment or once the correction is achieved both in the soft tissue, the hard tissue, and the musculature, there should be a consideration in mind that our aim is not only to correct it but also to retain it, and retain it for maximum period of time. Maybe say it has to be retained lifelong. So this is the defect that I was talking about. Many a times patient comes with such big defects and you hardly have any teeth present, and then the teeth that are present also have very less bone for holding them. Plus you have only 2 molars from which you can take anchorage for expansion. And doing ABG in such severe cases or severe bone defects is also a big challenge. So when you are doing so much of work, when you take so much of efforts in correcting such big defects, not only big defects, even the small defects, when you take so much of efforts, the consideration as an orthodontist and as a cleft care provider that you should have is you should be able to retain them. This is the class 3 condition which you usually see when the patient reports to you very late. Once the lip repair is done, once the palate repair is done, the patients hardly turn up for the orthodontic treatment that time, and over a period of time when they get adult and they feel the need to change their aesthetics, that time they report. And this class 3 is so severe that correction requires of course a surgery, but retaining that is also a challenge because the musculature would have developed that way over the period of so many years. So this is the protocol that we follow in our institute for the retention, or for you can say starting from the treatment, that is the first month of the treatment, till the complete rehabilitation of the occlusion and the face, the orthodontic surgery, everything is done. So this is the protocol for the management of cleft. The first thing, as we all saw from yesterday, is the pre-surgical nasoalveolar molding, which needs to be done. Again, there is a controversy regarding that, whether it should be done or not, but we at our institute follow this protocol that whenever a patient is born with a cleft lip and palate, we have requested the pediatricians to send them to our department, and we start with the pre-surgical nasoalveolar molding. Then the lip repair is done once the child is a little older and fit for the surgery. Then by say 2 years or 2 to 3 years, palate repairing is done. And also speech training is a mandatory protocol whenever the cleft patient comes to us. And then comes the maxillary expansion, that is the orthodontic phase then starts once the speech training is done and there is an improvement in the speech. maxillary expansion, maxillary orthopedics using face masks or chin cups at times, or tandem appliances. This is routinely done in the department. And then once the teeth are there and once the previous interceptive orthodontic procedures are done, then we go ahead with the orthodontic treatment of the patient. And once that is completed, once the pre-surgical orthodontic treatment is completed, then the patient is posted for the orthodontic surgery. And then the prosthetic rehabilitation and the revisions and the other type of surgeries that are required, like the nose correction, the maxillary protraction surgeries, or the mandibular setback surgeries, or the bijaw surgeries as required by the patients are done. So this is a protocol followed for every patient in our institute. So let's see how each of these things, starting from the lip repair till the orthodontic surgery, how the retention should be planned, or how the retention protocol should be followed for these cases. If we look at the review of the literature regarding the nasal morphology corrections and the retention, there are both proponents and the opponents regarding these procedures and the retention that is observed in these patients. Like the Ross and McNamara way back in 1994 said that there is no lasting effect of the aesthetics on the lip and nose. Means over a period of time it loses the correction, and the nasal correction relapse as early as the first year of life. And it was seen to be stable till 3 years of life, which could be due to the differential growth of the face. One study was done in our department also, and it was proven that the lip repair and the nose repair that is done in the pre-surgical infant orthopedics or the pre-surgical nasoalveolar molding relapse back in 1 year. But then again, there are proponents of these things also. Like if we look at the proponents who say that the nasal morphology correction is retained once it is done, Singh et al. In 2007 concluded that the three-dimensional laser facial morphology virtually was indistinguishable from the non-cleft, and the VAS scale showed a positive effect at the age of 4 years, which was maintained till 9 years. So the proponents say that these corrections, the pre-surgical nasoalveolar molding and the nasal corrections should be done when the child is as young as 1 to 1.5 months old. So with that, the latest, if we look at the latest review that was published in the year 2020 by Suleiman et al., they reported a significantly improved and maintained nasal symmetry up to as long as 15 years of age. There are various meta-analysis and the systematic reviews also, which says that the better and the permanent nasal symmetry is evident if it is intervened or if it is corrected in the pre-surgical nasoalveolar molding and infant orthopedic stage, that is 1.5 years. So there are both proponents and opponents of whether these corrections should be done as early as 1.5 years. But if you look at the some of the articles recently, like from 2018 and 19, many of the authors have used nasal conformers, which are also called as nasal retainers, which are typically used to correct or retain the nostril shape after the primary cheiloplasty surgery. So once the lip repair is done, then the focus should be on the correction of nose, because whenever there is a cleft lip alone or cleft lip along with the palate, it is seen that the nose droops down and it tilts towards one side, and there is a difference in the symmetry of the two nostrils. So there are many nasal conformers, or you can call it as nasal contours, which are available commercially, as well as they can be customized, And these nasal conformers, when used in the initial stages of the child's life, they have proved to be giving better aesthetics to the patient once they grow old. So if you look at this article from Journal of Oral and Maxillofacial Surgery by Spencer et al. In 2018, they said that use of nasal conformer after birth effectively improves nostril symmetry in patients with unilateral incomplete cleft lip. Also, Indian study was done by Dr. Jaideep Singh Chauhan et al. And was published in the year 2019 in the Journal of Maxillofacial Oral Surgery, where they have designed a simple and economical nasal conformer for cleft cases, and they have proven it to be very effective in the correction of these nasal conformers. So these are the different designs of the nasal conformers which are either commercially available or they are customized by the clinician as per the need. So some of these conformers comes or even are available online, and they range somewhere from 3,000 to 15,000. So these nasal conformers, they can be unilateral, like when it is indicated only for the correction of one side of the nostril. Bilateral, they can be used along with the taping, or they can be retained. Suppose they both the nostrils require the correction, they can even be retained with a nose tape, and they can be used simultaneously along with the pre-surgical nasoalveolar molding appliance also. These are some of the commercially available nasal conformers, but it is not only very expensive, but a very harsh and cruel nasal conformers. So the small earbuds, like we have our small headphones called earbuds, something like that can be customized and fabricated with the soft acrylic, and they can be used chair side. You can fabricate it and use it in your patients, because the socio-economic status of these patients who come to us is not so much that they can afford these nasal conformers, but for study purpose, these are commercially available. Then another method is lip tape therapy in patients with a cleft lip and palate. If the nasal contour is proper, only the lip taping, if done at the appropriate time, will also retain or will also give long-term retention for the patients with cleft lip and palate, especially when we talk about the bilateral cleft lip and palate cases. It is observed that the nasal contour or the nasal symmetry is not that much disturbed as much it is in the unilateral cleft lip, because the central columella that is there is proper and is maintained. So only the lip taping, if done appropriately and at the right time, along with the obturator kind of appliance, will provide lasting or the retention for a very long time. This is another article which was published, which talked about the effect of tongue appliances on the nasomaxillary complex in cleft lip and palate cases. So tongue appliances, in the sense, some appliances where we can provide guidance to the tongue, which will improve the speech. So the speech therapy, which helps in tongue molding and adaptation in proper direction, leads to the adaptation of these aids in bone molding and contouring the maxillary arch form. So many times when we are treating patients with cleft, we don't give so much of importance to the tongue or the speech. But if that is also taken into consideration, the what I will say, the once the importance or consideration is given to the tongue, the maxillary contour or the maxillary shape, the arch form, and the bone adaptation that occurs will help in the long-term retention of these corrections. So when we talk about maxillary expansion, then once the pre-surgical nasoalveolar molding part is over, and we talk about the maxillary expansion then, because as I said, it is a severely constricted arch that we come across in the cleft cases. It is a challenge, first of all, to do the maxillary expansion because of the lack of bone, the diminished capability or the quality of the bone, and the bone regenerative ability in the cleft size, and also the non-elastic fibrous tissue which is present in large amount there. So, if you look at this article by Dr. Talat Hassan, he said in 2008 that relapse tendency in maxillary arch width in unilateral cleft lip and palate patients with different maxillary arch forms. And he studied that it is very difficult to retain these maxillary expansion, and the retention period after the correction of the constriction or the correction of the posterior crossbite, it is a must because once the expansion is achieved, you remove the expansion appliance, go ahead with the palate repair, the ABG and orthodontic treatment. It is bound to relapse over a period of time. So numerous articles have been published in this regard. And this is a recent article from 2022 where a systematic review was done in this regard. And they have proposed that these are some of the different modifications that you can do for retention of the expansion that you do with cleft. So once you have achieved your expansion with whatever appliance you use, a cord helix, or you use a Hyrax, or you use a NITA expander for your expansion. But once your expansion is achieved, these are some simple wire bendings that you can do and adapt to the maxillary arch of the patient, and it will have a retention for as long as possible, which will help you in retaining the expansion that you have achieved. So these are simple designs that can be used: a modified transparatal arch or a modified wire which is extended till the second premolar. So these are the different types of modifications that you can do in your wire bending to retain. And the other advantage of these appliances is you can simultaneously do orthodontic treatment with them. So this is another method, one of the technique that is suggested in the literature regarding the reducing the relapse tendency post treatment in cleft lip and palate expansion, and that is by using an injectable estrogen nanodiamond hydrogel. So this is another technique that they have suggested, but not very popular, and not many studies have been conducted in this regard. So this is one example of the patient where this was treated in our department, where you can see the amount of maxillary constriction that is there in the patient of cleft lip and palate. And the NITA expander was used to do the expansion, and you can see the beautiful expansion that was achieved with that NITA expander. But once that expansion was achieved, a W arch kind of appliance was made and it was soldered to the bands. And this helped in not only maintaining the expansion that was achieved, but it also acted like a anchorage reinforcement device when you are doing orthodontic treatment. So when the pre-surgical orthodontic treatment was going on, this was kept throughout the treatment, and it really helped in retaining the maxillary expansion that was achieved. So from this, it came on to this, and it is retained that way. And this is the final picture of the patient after the orthodontic surgery. Distraction was done for maxilla. And this is how the patient looks. So not only in the transverse, but also in the sagittal plane, you can see the beautiful amount of correction that is achieved. So this is how the patient was pre-treatment, and this is how she became after the treatment. So once you are doing so much of correction, you should always give importance to retention. This is another patient where a boy where the expansion was done not with the NITA expander, but with a cord helix appliance. And once the expansion was achieved, you can see so much of expansion was achieved with cord helix. So if you don't have an aorta expander, it is not that you cannot do expansion in cleft cases. Even your properly made quad helix will help you achieve this type of expansion. And this is the PRP that was used along with the ABG for the bone formation, or which helped us in maintaining or retaining the ABG that was there. So this is post ABG, the retention with expansion that was maintained. So expansion followed by retention of expansion along with the bone grafting with the help of PRP. So such complicated or such multidisciplinary approaches when done, and apart from the treatment, when the retention is properly followed, you get such beautiful results. So this is an article regarding the use of bone grafts on the stability of expansion, because we usually think that once the expansion is achieved and you have kept appliance as a retentive appliance in the patient's mouth, it will retain. But even your bone grafts can help you in maintaining the expansion that you have achieved in the maxillary arch. So lack of investing alveolar bone often produces the correction of anterior teeth irregularities and limits orthodontic and prosthodontic rehabilitation. So the success of the graft is multifactorial, because the periodontal health of the surrounding graft tissues, the experience and the ability of the surgeon, the timing of the surgery, orthodontic management before and after grafting are shown to be the most important factor in this issue. So it is not only one person which is responsible for correction or maintaining or retaining the correction. It is a multidisciplinary approach. So there are numerous articles quoted in the literature regarding the alveolar bone grafting in patients and the maxillary expansion done along with the grafting material. So I will not go into the detail of the grafting, but it helps in retention. So this is retention after maxillary orthopedics. Like I was talking about, the face mask is commonly used in the department for maxillary protraction, and it is always given with the expansion. So expansion along with protraction when done not only helps or improves the protraction of maxilla, but it also helps in retaining the correction that was done. So this was a removable wraparound retainer in the maxillary arch for 6 months during the day and night for 2 years. In the mandibular arch, however, stainless steel wire with the intercanine bar can be given. So a simple appliance like a wraparound retainer can also be given post expansion to retain the expansion that is achieved or that is done. Even your Frankel regulator. Now, very few of you might be aware that in cleft cases, even the Frankel regulator can be used as a retention device. So Frankel function regulator as a retention protocol after protraction face mask therapy has been documented in the literature, and this can also be used as one of the method. This was another article which was published by Paula Cosa, and which stated the treatment and post-treatment effects of facial mask combined with a bite block appliance in class 3 malocclusion. So something like a twin block kind of appliance can also be used for retaining the correction. Even the use of face mask for post-operative retention in cleft lip and palates has been documented recently. And immediate and late follow-up effects of class 3 early correction in cleft lip and palate treated with maxillary protraction is also documented in the literature, that once the immediate treatment is done, the face mask can be used, the protraction face mask can be used as a retention for the correction of these things. Like this is the kind of appliance I was talking about, the twin block kind of appliance which we give to the patient for the mandibular advancement can also be used as a retention appliance. Bionator or kind of a modified expansion appliance with the jack screw can also be used for retaining the anterior segment of the maxilla. So these are some of the simple appliances that you can fabricate easily chair side, and you can use them for retention in cleft cases. Then comes another aspect, that is retention with prosthetic rehabilitation after orthodontic treatment with or without orthopedic surgery. So when the prosthetic rehabilitation is done after orthodontic treatment, it is again a neglected fact that retention is not given importance. Once the orthodontic treatment and once all the pre-surgical nasoalveolar molding and all the orthopedic corrections are done and the patient is referred for prosthetic rehabilitation, no consideration is ever given for the retention. So these are some of the simple appliances or prosthodontic appliances that can be used. So apart from providing the missing teeth, they can also, with some minute changes or modifications in them, can help us in maintaining the corrections or maintaining the defects that are there in the patient. So removable partial denture or implant supported partial denture is the best thing. But you can even do some simple RPD kind of appliances which can be given to the patient, which apart from retaining, if some extension is given, and it can help in obturating the defect also. So these are the considerations that should be given when the patient is referred for prosthetic rehabilitation. Now, this is a kind of correction or rehabilitation, like if you can see, it can be done, the orthodontic treatment for getting this canine down. And in order to retain the defect, RPD kind of appliance was given, which not only replaced the missing tooth, but it also helped in obturating the defect that was there in the patient. So this is simple orthodontics along with prosthodontics that can help you. Now this is one study where they have modified the removable partial denture with a soft palate lift up kind of appliance. So this is a follow-up study of cleft lip and palate patients treated with orthodontic, secondary bone grafting, and prosthetic rehabilitation. So this is done for lifting up the soft palate. So it, apart from providing the anterior missing teeth to the patient, cast partial denture is modified in such a way that this posterior portion helps in lifting of the soft palate when the patient talks. So it improves the velopharyngeal insufficiency and helps the patient in improving his speech. So such kind of modifications or such kind of innovations with prosthodontic appliances can also help in retention apart from providing the aesthetics to the patients. So this was the modification that we have done in our department with a simple acrylic plate and the retentive class. We just extended a wire along with acrylic, soft acrylic in the posterior region, and that helped in improving the patient's speech and improving the velopharyngeal incompetency that is usually seen in cleft cases. This was a review paper which summarized the 60 years of progress in orthodontic care of patients with complete cleft lip, alveolus, and palate. And this progress and evaluation of orthodontic treatment showed that clefts have taken slow and sometimes curious route to the present day standards. And nonetheless, there has been a remarkable progress that has been made in the orthodontic treatment that is given for cleft lip and palate. So this was a very good study for, which summarized the 60 years of follow-up and the ways by which orthodontic treatment had helped in retaining the corrections done in cleft lip and palate cases. So I think that's all I wanted to talk about the small topic of the retention protocol that should be followed when we are doing cleft care. And it is something that is a neglected area, a gray area, but the efforts that are put in by the orthodontist, the speech therapist, the surgeon, they are complemented very well if the retention is proper. And it is, of course, every cleft care provider's dream that whatever corrections that are being done in the patient, they retain long time. So with that, I would conclude my presentation with this take-home message that long-term age changes in skeletal and soft tissue surrounding the teeth means that relapse after orthodontic treatment is unpredictable, but it is likely in cleft cases due to multiple reasons. And as it is difficult to predict which case will relapse, every case should be treated on the basis that it has the potential to relapse and long-term or lifelong retention may be required. So there remains a need for further randomized clinical trials to evaluate the use of different types of retainers and retention protocols depending on the types of cleft, the types of defect, the amount of available tissue, and the remaining growth. So these protocols needs to be developed. So some clinical trials in these areas needs to be done. So as it is rightly said that stability equals success, and we should never give up because there is no such thing as an ending, but just a new beginning. So whenever you think that a cleft patient is completed or the cleft care is completed, you should always think that there is a new beginning, and that beginning is the retention. So these are some of the pre-treatment and post-treatment patients photographed from our department where patients have followed up properly and they have really improved aesthetics and they are doing very well in their life. So this is a dream of every cleft care provider, that whatever corrections they did from the pre-surgical nasoalveolar molding stage till the orthognathic surgery give them these results. So that is the end of the topic. Retention protocol in cleft patients, strive to seal the healing. Thank you. I once again thank the organizers for giving me this opportunity and considering me able to be a part of this symposium and speak along with the stalwarts of the cleft care providers in the country. Thank you very much. Over to you.
The role of retention cannot be overlooked for a long-term functional and aesthetic harmony for the CLP patients. Thank you, sir, for such an informative lecture backed with extensive literary evidence. Your lecture has given us many points to ponder over. I now request Dr. Achal, sir, to kindly present Rizwan, sir, the certificate.
Thank you, Dr. Rizwan, for such a wonderful presentation. Definitely, stability is something we should plan in advance. And yes, we must treat each case considering its potential for relapse. Thank you for such a wonderful presentation, Dr. Rizwan. And we are really very sorry for the technical difficulties you faced in the beginning. Thank you so much.
I should apologize for the technical glitch that happened. Anyways, that is a part of the online symposium. Thank you very much, ma'am, for giving me this opportunity, and compliments and regards for organizing such a wonderful symposium. Thank you, ma'am. Thank you.
Thank you, Rizwan. Thank you so much. Have a good day.
Thank you, ma'am. Thank you, sir. We have been listening to eminent 5 speakers deliberating in the areas of comprehensive management of cleft lip and palate since morning. All these valuable insights gave us a new perspective that one should adopt in their practice. A brief pause for lunch is much called for. We shall resume the webinar sharply at 2 p.m. The participants can join back using the same link.